Get the ball rolling. Can I welcome everyone to the fourth hearing of Portfolio Committee number 2's inquiry into health outcomes and access to health and hospital services in rural, regional and remote New South Wales. My name is Greg Donnelly and I'm the chair of the committee and the inquiry. The inquiry examining health outcomes, access to services, patient experience, planning and capital expenditure in rural, regional and remote New South Wales. Before I commence, I'd like to acknowledge the Wiradjuri people, who are the traditional custodians on this land that we're having our hearing today. And I'd also like to pay respects to elders past, present and emerging of the Wiradjuri people and extend that respect to other Aboriginals who may be present this morning, this afternoon, or maybe joining us with our live streaming. I just might pause there and say we're very proud to be able to announce that we are live streaming this hearing today. And in fact, I'm informed that this is the first time any parliament in Australia has actually remotely live streamed a hearing. So that's great news. And I think it's very important and appropriate that Parliament, as it goes about doing its business, particularly with respect to its public inquiries, wherever it goes, makes available the very best technology and facilities to enable full participation by the citizens of the state. Today we will be hearing from a number of stakeholders, including local councils, private citizens, advocacy groups and health services. And I thank everyone for making the time to give evidence to this important inquiry, and particularly those who join us for the first session this morning. Before I commence, I'd like to make some brief comments about the procedures for today's hearing. As I've mentioned, the hearing is being broadcast live via the Parliament's website. Now, I said, and it is true that this is the first time, and it's been treated as a trial to ensure that we can get any matters ironed out, so we can do this as we go around the state. A transcript of today's hearing will be placed on the committee's website when it becomes available, and because this is a public hearing of the New South Wales Parliament, Hansard are with us, and of course Hansard is the official record of the Parliament. In accordance with broadcasting guidelines for media representatives, they're reminded that they must take responsibility for what they published about the committee's proceedings. While parliamentary privilege applies to witnesses giving evidence today, it does not apply to what witnesses say outside of their evidence at the hearing. And I therefore urge witnesses to be careful about comments you may make to the media or to others after you complete your evidence before us. Committee hearings are not intended to provide a forum for people to make adverse reflections about others under the protection of parliamentary privilege. In that regard, it is important that witnesses focus on the issues raised by the inquiry's terms of reference and avoid naming individuals unnecessarily. All witnesses have a right to procedural fairness according to the Procedural Fairness Resolution adopted by the Legislative Council in 2018. If witnesses are unable to answer a question today and want more time to respond, they can take a question on notice. That's perfectly acceptable. Written answers to questions taken on notice are to be provided back to the committee within 21 days. If witnesses wish to hand up documents over the course of giving their evidence, they should do so through one of the committee secretariat staff and they'll assist you. In terms of audibility of the hearing today, I remind both committee members and witnesses to speak into the microphones. There are two microphones. One is for the amplification of a voice in this room, and the one on the tripod is for Hansard. Okay, so I think, do people down the back hear me pretty clearly? Okay. If for some reason a witness is not audible, just put your hand up. I can ask them to bring the microphone forward, but that's obviously not a problem at the moment. And finally, could everyone please turn their mobile phones to silent for the duration of the hearing? So with that part of the formalities out of the way, can I now welcome our four witnesses who join us this morning. First up. Now what I'll do, starting from my left, moving across to my right, I'll get each individual to state their name, their position title, and swear either an oath or an affirmation, whichever you prefer. The words of both should be before you. So we'll go through that first, and then we'll turn to the matter of opening statements. So we'll start with Councillor Orban.
Thank you, Mr Chair. Yes, Warren Orban, Councillor on Bathurst Regional Council. And I'm taking the oath today.
Thank you.
And I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
Thank you, Councillor.
My name's Neil Southorn. I'm a member of staff of Bathurst Regional Council, responsible for planning and economic development.
Thank you, Mr Southorn.
I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you, Mr Southorn. Councillor Yanadi.
Councillor Anielo Yunutsi from Warrumbungle Shire Council. I'll take the oath. I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
Councillor and Mayor of Dubbo Regional Council.
Thank you. Ben Shields, Mayor of Dubbo Region, the oath. I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth. So help me God.
Thank you very much. So what I'll do is I'll invite opening statements. Your submissions, and thank you for the time put into the preparation of very well submissions, have been received, processed and stand as submissions to this inquiry. So as Mayor Shields will be aware that the Dubbo Regional Council is submission 435. The Warrumbungle Shire Council submission stands as submission number 382, and the one from Bathurst Regional Council stands as 245. So we have all those. You can take them as read, so you don't need to extensively refer to them in your opening statement. Members may well have questions arising from the content of those submissions, but if you could just set the scene for the inquiry with your opening statement, and then if you're agreeable, what we do, we'll move between committee members for questioning. And just to confirm, we have representatives here from the Labor Party, the opposition, myself and Honourable Phil Secord. We've got Honourable Kate Fairman from the Greens, Honourable Emma Hurst, Deputy Chair from the Animal Justice Party, Honourable Natasha McLaren-Jones from the Liberal Party, Honourable Lou Amato from the Liberal Party, and the Honourable Wes Fang from the National Party. So we've got a good cross-section of representatives from the broad range of members of the Legislative Council. So without any further ado, I'll pass it over to Councillor Orban.
Thanks, Mr Chair. Would you like me to stand or?
No, feel comfortable. Just sit there.
No, very comfortable.
Thank you for asking, but they're perfectly comfortable. Yeah.
That's fine.
Thank you.
Great. Yeah, listen, Bathurst Regional Council and our community at large has been and remains concerned about the inadequate level of health services to the Bathurst community. Now, Bathurst is a beautiful city to live, and we do have quite a lot of people beginning to come our way to populate our city. A bit of background for you. Population in 2008, with the planning for our new hospital, the forecast population for Bathurst was 43,000 by the year 2036. The city population from the Australian Bureau of Statistics at June 2017 was 42,900. So we're about 15 years ahead of ourselves. And that does flow into the size and the services of the hospital that's offered at the moment. It's forecast, our population is forecast to reach 53,000 now by 2036, so it's a fair jump. But with the advent of COVID-19 bringing about the work from home syndrome, we find a lot of city folk are already moving to the country, and who knows what our population is going to be in 2036. It could be way, way more than the forecast. At the moment, our population, combined population of referral towns, Lithgow, Oberon and Blaney, and Bathurst, is just over 76,000. And our submission outlines how there's a potential for greater collaboration between health practitioners at Lithgow and Bathurst, public and private, that would enhance services available at each location. Can I just touch on the budget for our region? the local health district, the Bathurst budget for 2019-20 was 88.9 million, which was up about 2.6% from the previous year, which is just touching on CPI. Dubbo, 138.2 million, and Orange, 151.1 million. That's a difference in our regions, which Bathurst should be getting a much larger slice of that pie. We are way underfunded, and it shows in the service levels that are being offered at our hospital at this stage. The most defining of Council's concerns centres on the reluctance of the LHD to recognise that concentrating resources on Dubbo and Orange in the current two-hub referral model of the LHD significantly disadvantages the community of Bathurst and undermines the status of treatment of broken bones to be sent to Orange for basic medical procedures. I mean, there's a lot of facts that have been put in this submission from people that have been sent for the slightest thing, like a dislocated finger, have to travel to Orange to get that fixed. Now, that's just not on as far as we're concerned.
Can I ask, Councillor, just for the people who might be watching this and not
Yes.
familiar with the distance, roughly how long is that as a trip, just in a vehicle? Just roughly.
On a good run, about 45 minutes.
45 minutes. Thank you.
Yes.
Just a bit, might not be familiar with the geography,
Yeah. And I actually started an action group on my own behalf for one of my, I had surgery in Orange a couple of years ago, and I came out of surgery at 8:40 on a Monday evening, and when I was told I was fine, they said I had to go home. Now, I got transported up to Orange in a patient transfer vehicle, so I basically had to get my own way home at, it was approximately 9:30 on a Monday evening. So, which was unexpected, and I had nothing organised. And this has been shown through a heap of different testimonials that this is almost the norm, which is a terrible situation. Further two-hub model disadvantages the status of Bathurst Hospital itself and the capacity of both the public and private hospitals to attract new staff. They being attracted to positions in Orange because of the scale of services occurring at Orange. Bathurst Hospital is unable to fully function as a training facility. These factors further accelerate the decline of services in Bathurst. Now, it's come to pass, unfortunately, over the period of the last few years that we have lost a heap of specialties at the hospital. And we are in dire need at the moment of respiratory medicine. We need cardiac services. There's no coronary care ward. Anyone in Bathurst, and this is a very scary statistic, anybody in Bathurst that has a heart attack will be taken to the Bathurst Health Service and given initial treatment there, but then has to be transported somewhere else, usually Orange or further afield. Now that also, our community is saying that is not on. With a heart attack, which are fairly, they're quite common occurrence, for the Bathurst community not to be able to have treatment in their own hospital, to have to be transported away, with family getting involved in that sort of thing as well, it's a really poor situation. There's a huge need for a 24/7 orthopaedic service. As council, we bring a heap of events to the city in Bathurst, and we have 5 international motor racing meetings per year, plus every other weekend there's a sporting competition going on. We don't have orthopaedic services in the hospital of a weekend, so anyone that has a minor ailment that presents to ED in Bathurst is straight away sent to Orange, and it's just not on. Maternity, O&G, there's no neonatal intensive care ward, so anybody that has a baby and has problems, again, transported away. And especially in that field, I mean, that involves mother, father, parents, grandparents, all having to travel away. So it's a big uprising in family. So basically, we have a long list of needs, and it's needs. It's not wants, it is needs. These have to be filled. There remains a profound lack of senior staff in Bathurst, and the health service remains supported in key areas by locums and fly-in, fly-out doctors. Approximately 33% of the staff are locums, which brings little to no economic benefit to our city. If the reputation of Bathurst as an attractive town in which to live is damaged because of inadequate healthcare, the city will not attract new industry or business, and these downstream effects will leave it in economic decline. What a pity that 2014 Hoyle report was not acted upon. So, in conclusion, I'll just give you a couple of lines and I'll let the next speaker go. But Council has been patient in waiting for long overdue improvements to health services to the community of Bathurst. But frustration is escalating both in our council and especially in our community. Council hopes the inquiry can encourage the government of the day to prioritise this delivery. Thank you.
Well, thank you, Councillor, for a very clear and strong opening statement. It's set the scene well for some questioning shortly. Councillor Ennisi, sorry, I assume that you should ask, do you have an opening statement, or that's been covered off by Councillor?
Thank you, Mr Chair, but certainly Councillor Orban has summarised it and the submission is there. If the committee gives me an opportunity, I'd like to talk about the economic impact, quantify some of that stuff that a lack of investment in health services creates.
Do you want to do that in an opening statement, or can we do that through questions?
Can do through questions.
Thank you. That will be helpful if we can do it through the questions.
And there's also one topic in the submission that goes to something not right in the system, and I'd like an opportunity just to talk through some of those concerns.
I'm sure there'll be members.
Thank you.
Thank you. Councillor.
Thank you for the opportunity. I'm here representing the Warrumbungle Shire Council. We're a small council, not even 10,000 population. It's a difficult geography. It's a large geography. We have a very poor population in terms of economic measures. It's getting poorer. We have a high Aboriginal population, and we have a lot of issues with respect to getting access to adequate health care. The problems we've heard mentioned by Bathurst are even more serious in our shire, because even very basic things are getting transported beyond the surgical things we've heard mentioned by Bathurst. We have 4 hospitals in our shire. We have Coonabarabran, we have Barradine, Dunedoo and Coolah. The latter 3 are in fact now called MPSs rather than hospitals, but in many ways they still have to perform the functions of hospitals. Weekends, after hours, it's very common to not have medical cover at 3 of those hospitals, and at Coonabarabran at times we struggle as well. So there have been times in our shire that there has been no medical cover throughout the shire. I think that's a very dangerous situation and a very sad situation. And I would hope that this committee and its findings and its recommendations may lead to an improvement in the provision of health services to those most in need. It's also worth noting that it's already been mentioned that there is a problem in the system. There's a cultural problem. In fact, I think it's beyond a cultural problem, it's a governance problem. Your biggest problem in the health system in New South Wales is governance. Secondary problems are those of money and those of communication, but there's no point communicating well and spending bucket loads of money if your governance systems are not right, and I believe they are far from right. I think you need to look beyond the LHDs and look at New South Wales Health as an organisation. Its top-down approach, its poor culture, its very managerial style, its inflexibility. If you can address those problems, then you'll give the LHDs the ability to do things and to be more flexible and more agile, and therefore get the job done. As things stand at the moment, I can't see any way of moving forward to improve these problems whilst New South Wales Health remains so opaque and so unaccountable. You really have a problem there that you need to fix. Thank you.
Thank you, Councillor. If I could just also, just for the record, acknowledge that you are a medical doctor, and I think it's worthy of acknowledging that, and to thank you for the particular insights you're able to bring.
So I'm here to represent the council, but
Yep.
yes, I do have other roles. So for the information of the committee, I've been a VMO in the Western LHD for 25 years. I've owned my own practice for 25 years. I've also got very intimate involvement in urban general practice. My wife and I own a practice in Camaray as well, so we really understand the difference between rural and urban medicine. I'm also a clinical associate professor at 2 universities, so I'm heavily involved in medical education, and I serve on a number of important committees at the federal level as well. And at the LHD level, I'm heavily involved in training of hospital doctors, but that's a role that's about to cease, and that's a concern in itself, and we can perhaps talk about that later.
Thank you very much. I just thought it would be useful and helpful to have that on the record in terms of giving some particularly intimate perspective in the matters we're going to be looking at this morning. Mayor Shields, welcome.
Well, thank you, everybody, and it would be remiss of me as the mayor of this area not to welcome you all to Wellington. And I suppose it's not, it is ironic that we are meeting in a former Wellington hospital right now. So I have very, very similar issues to the health situation in this area, but very different at the same time. I feel as though I'm wearing 2 hats because I'm the Mayor of Dubbo and also now Wellington, which was forcibly merged with Dubbo. The main issue I wish to raise with you today is the dire state of Wellington's health. This town services a population of 10,000 and living within it is 5,000 people, and yet there is only 1 doctor practicing at Wellington Hospital. We have a situation where Wellington does have social problems. We do have a low socio-economic population here in Wellington. It's not as easy for a lot of Wellington residents to simply get in a car and travel to Dubbo for medical treatment. They have to rely on GPs here in Dubbo, here in Wellington. Apart from the local Aboriginal Medical Service, which does a fantastic job here, we only have 1 practicing GP. That is something which, in my mind, is appalling. I believe on the federal front, we have a massive problem with Medicare. It is obvious that we need a sliding scale with Medicare. So Medicare is paid, a higher rate is paid to bush doctors and doctors in harder to reach locations, similar to what the state already does when it comes to teachers. And we should look at, and we shouldn't necessarily be paying Medicare to some of those well-off areas of the state. It's not about paying more money into the health system. It's about making sure that what money is spent is going to the right places. There is so many anecdotal evidence here in Wellington that I could give you. If I put a call out to the community to give me your health stories, I'd be flooded with probably 200 within a day. But I will give you the story of a young lady who turned up to Wellington Hospital. Turns out she had appendicitis. She waited all night.
Is this a recent example?
Sorry, this is a recent example at Wellington Hospital. Waited all night for a doctor. She was only just told that she had appendicitis early in the morning. So the best she could do to get to Dubbo with this appendicitis problem was to drive herself. That is unacceptable. It really is. It really is frustrating for me as someone from Dubbo, as this newly merged council, that effectively we were given, Wellington merged with Dubbo because there was a lot of social problems, there was a lot of problems with funding, and it was decided that to bring Wellington up, it would be best if they were merged with Dubbo. From a local government front, yes, Wellington is improving fantastically. There's so many new facilities that have gone into this place. everything from new pools to new tourist attractions. There's a lot more being spent on urban infrastructure. But I have to say, coming from the state, I don't necessarily see it going, that same increase going into the bread and butter issues of Wellington. Again, only having one doctor here is unacceptable. As much as they claim, oh yes, we're advertising, the reality is they could get more doctors if they really tried. My frustration is that we are getting on with the job here in Wellington in turning it around. We've had a massive increase in DAs coming in. In fact, the last couple of years of the former Wellington Council, there was next to no DAs going in. Now we've got dozens going in for Wellington. Wellington is on the grove, but I really need the state government to come to the party too and help Dubbo Regional Council pull Wellington up even further. Thank you.
Thank you. Before we progress to questions, it's remiss of me, I should have welcomed the state member of Dubbo, Dougal Saunders, that joins us today, and I understand we're joining us tomorrow. Sorry, I should have mentioned at the start, I passed over it, but you're most welcome, Dougal, and thank you for making the time available. Well, we'll commence our questioning. We'll start with the opposition. Honourable Secretary.
Thank you, Mr. Chair, and thank you for your submissions. We've been through them. We appreciate them. I would like to start my questions with the Deputy Mayor of Warrnambool. In your submission, you say that the examples that are provided in the submission, they are genuine examples.
Yes, they are.
They are genuine examples. Okay, I just wanted to clarify that. So, and in your submission, you say there are four hospitals in Warrnambool. 4 hospitals. Of those, and those hospitals are, what are they?
Coonabarabran,
Yep.
Barradine,
Yep.
Coolah and Dunedoo. Now, the latter 3 are now classified as MPSs.
Yep, I'm familiar
But
with
this is one of the things that we're dealing with here. It's this opaque governance, this failure to define things properly and to communicate well.
Now,
You know, are they hospitals, are they MPSs? At times the doctors and the nurses are expected to perform to the level of a high-level hospital. Someone comes in with a major trauma. Then at other times they're told, well, you're just a nursing home and you're not going to be staffed and resourced properly. So we've got to address these issues.
in your submission, you said that there are 4 hospitals. Now, in the submission, you say, and I quote, "It is not uncommon for hospitals in the Warrnambool Shire to run out of basic antibiotics."
Correct.
What do you use antibiotics for? I know you're a professor, you're a doctor, and you're a counsellor. Just for the benefit of the people on the committee and people viewing this, what are antibiotics?
Antibiotics are used to treat infections.
Don't you think that, in fact, it's extraordinary that 4 hospitals in New South Wales would not have antibiotics?
I think you'll find that more than 4 hospitals suffer this problem. I'm not saying that there aren't any antibiotics in the hospital, but antibiotics are complex and you need different antibiotics for different conditions. And sadly, there are times, and those times are too frequent for my liking, where we run out of basic antibiotics to treat basic conditions, particularly after hours. Say a mother brings in a child with a throat infection or an ear infection. We have had times where we haven't had even the basic antibiotics. I'm not talking about antibiotics you use in an intensive care unit at RPA hospital. I'm talking about basic things to treat basic conditions.
So, basic antibiotics you've run out at these hospitals. So what do you, as a doctor, do if you're in a hospital and you run out of antibiotics?
Well, you apologise to your patient, explain to them the situation, how regrettable it is. You send an email to management hoping that they might address the problem. Sometimes it's addressed, sometimes it's not. You try to find alternative solutions. You hope that perhaps the pharmacy down the road might be still open and somehow can find the antibiotic you need that way. Sometimes you choose a 2nd or 3rd line antibiotic that may not be as appropriate or as efficacious.
Now,
that's just life as a rural doctor in a small town these days.
So not by your own choice, but you're forced to make do or to cut corners.
Correct.
Okay. Now, we previously held and conducted evidence in Deniliquin and Cobar. And in Cobar, we were told that there were a number of hospitals that didn't have blood supplies. Now, the 4 hospitals that are in your shire, do you have blood supply in those hospitals?
No, we don't, and that's a concern that doctors have raised for many years.
So you run out of antibiotics and you have no blood supply. Do you take emergency patients in those hospitals?
Yes, we do.
So
The issue of blood supply is complex though, and in fairness, the need to give blood and to carry blood is nowhere near what it used to be once upon a time. Having said that, Coonabarabran is on 2 highways, and road trauma is not an insignificant problem on 2 highways. Plus we have a national park and there is trauma there as well. I would have thought that perhaps having blood at one of the facilities in the Shire might make some sense. What we do get though is this continual obstruction from New South Wales Health and the blood bank itself. It would be unfair to blame such a problem on the LHD itself. Now I think the LHD could do a lot more pushing back against these policies that I don't think are serving us well, but these are problems that we see at the state level.
But you do say that you've run out of antibiotics and there's at times you've run out of antibiotics and there's no blood supply.
The antibiotic problem is an LHD problem. It's an LHD administration problem at the pharmacy level. The blood problem is a state problem.
Now, what do you do in those 4 hospitals? And you said there are times when there have been no doctor on call in those 4 hospitals in the Shire. Does that happen very often?
It's very rare because Coonabarabran almost always has a doctor. We fight tooth and nail to make sure we have doctors in Coonabarabran, and the residents of the Shire know that they can gravitate to Coonabarabran and be seen face to face. At times that comes at great personal sacrifice for the doctors in Coonabarabran because we end up carrying the can for the other towns in the Shire.
What do you mean by that? Do you find that you're doing extraordinary hours to support the community?
Well, we all have lives, we all have families. For some of us, our families don't live in the district anymore, and there are study commitments and personal commitments. And sometimes if the LHD cannot provide locums or find doctors or recruit enough, we end up having to modify our personal lives and our family lives just to make sure that someone's around to do the work.
Now, you talked about some of the three of the hospitals are MPSs. Do you find that they are relying on telemedicine?
They do rely very heavily on telemedicine.
Okay, so in your submission, and I quote, you say it's a vexed subject.
Very much so.
So what do you mean by that?
Well, telemedicine is a term that's become very common nowadays, but it means so many different things. So you need to be clear on what you're talking about. Telemedicine in the community with GPs working under Medicare is one thing. Telemedicine as a specialist tool to reach out to remote patients is another thing. Telemedicine trying to keep hospitals afloat and keep emergency departments afloat is yet another thing, and it's the most complex of those 3 that I've just mentioned.
Now, what's the time for a wait for an appointment for a GP in your shire?
In the Shire, it's hard to generalise because each town has its own complexities, and I'd like to think that all GPs have systems in place where acuity can come into it. In Coonabarabran at the moment, the waiting time's blown out to somewhere between 1 and 2 weeks. There have been times where it's been 5 weeks. There have been times when it's 1 day. It just depends on who's around and what's going on.
Now, Councillor Shields, in Dubbo, we were told that there's a wait in Wellington, 2 to 3 weeks. Is that your experience?
Yes, it certainly is. There is a lot of people in Dubbo who are struggling to get a GP, and it also isn't helped by the fact that we've got so many new people arriving in Dubbo, moving to Dubbo. They find it very, very hard to get a GP. That is the basis of it, and it is up to 2 to 3 weeks, yes.
2 to 3 weeks, and does that impact on the hospital itself? Do people find themselves presenting with triage 4 and 5s?
Well, they're presenting to the hospital when realistically it should have been handled by a GP. So that does flow on to the hospital. But in defence of the government here, they have actually put significant amount of investment into Dubbo Health Services. I honestly can't stand here and just throw doom and gloom on the government. They are both federal and state. They have put a lot of investment in health in Dubbo, but not necessarily in the right areas. And those basic health services, particularly here in Wellington, is being totally left behind.
Okay. Oh, sorry, Greg.
No, that's fine. We will go past the time to conclude to make sure everyone gets about 10, 12 minutes scrutiny. So the Honourable Member Hurst.
Great, thank you.
And then the Governor.
I might move on to Councillor Orban. You made an interesting observation in your submission that Bathurst Hospital seems to have difficulty obtaining and retaining staff, even though other sectors in Bathurst don't have the same problems attracting staff. Do you think that that relates to the fact that it can't function as a training facility? I think you mentioned in your opening statement. Yeah. Is that also because it's missing services? What do you sort of pinpoint as some of the issues there?
Yeah, I think from my perspective, I guess the Orange Hospital has really gone ahead leaps and bounds in numbers of staff, specialists. I think Neil can actually get some numbers for you on that, right. Which are fairly damning numbers. And yeah, look, there's not a doctor that wants to train in an area where there's no support, and that's what we find in Bathurst, that they would much rather train in an area such as Orange, or maybe even Dubbo, where if they're coming out in the region, where there is actually support. And
what do you mean by support?
Well, other doctors to, you know, bounce off and that sort of thing, and there's just nothing. And the numbers, I could quote in ONG, I think we've got, it has to, or it should have 4 specialists operating in that department. We've got 1. We can't do any training there. ED, there's same thing. There's not a major doctor there. What do they call it? FACM. So therefore, there's no training facility there. Nothing at all. And that's what we need in Bathurst to actually get the hospital starting to build again, is get some training facilities started. We really need the actual training facilities and more doctors to take up positions in Bathurst. And as you say, why can't they? We get a lot of feedback from doctors in the hospital saying it's a cultural thing in the hospital. There is a problem in the hospital running, and in the bureaucratic side of it, and that's where the problem lies. We really need to get more into a medical health centre rather than a bureaucrat centre. And I feel that's where the problems lie. But if you want to get Neil to quote you some figures there.
Yeah, I thought it might be a good opportunity actually to go back to something that Neil said in his opening statement about the financial impacts, which I think would probably quite relate to that other question as well, if I could get you to speak to that.
Thank you. So I've got some data from the Federal Government Department of Health, which goes to their health workforce data of 2019, and that's divided into Central West local government areas. One of the indicators is the number of medical practitioners per 10,000 head of population. Bathurst, 32.3. New South Wales benchmark, 44.6. So Bathurst minus 12.3 compared to benchmark per 10,000 head of population. And Orange, and we've got no problem with Orange having the right level of service. It's the distribution of that service. 77.7 medical practitioners per 10,000 head of population. If you translate that to the population of the local government area, rather than per 10,000, Bathurst is minus 53 medical practitioners for the population New South Wales benchmark. Orange is plus 141. Dubbo plus 4, so on benchmark. But of course, the regional cities operate for a population catchment that goes beyond their local government boundary. But if the population of Lithgow is added to the population of Bathurst as part of a broader catchment, and the Lithgow community is served by the Nepean Health District, not the Western New South Wales Health District, but if it was, then that'd be minus 102 medical practitioners compared to the New South Wales benchmark. And we all have a lot of sympathy, and we worry about our more remote and smaller colleagues in local government in New South Wales. But this is Bathurst, a premier regional city, and still not anywhere near New South Wales benchmark. Pharmacists, Bathurst minus 15 compared to New South Wales benchmark, Orange plus 19. Physiotherapists minus 16, dentists minus 10. Nearly every category of medical service is, by that benchmark, underserviced. So if those 53 medical practitioners were in Bathurst, to bring it up to New South Wales benchmark, that would create 94 direct jobs using the National Institute of Economic and Industry Research methodology, and that would have an economic impact of $8.7 million every year. There's a jobs multiplier because every one of those professional positions brings a ripple effect through the local economy, through the New South Wales economy, through the national economy, and that would create 137 additional indirect jobs. So that it's not just the human side of these issues, it goes to the welfare, the economic welfare of the community as well.
Thank you.
Thank you. What has been particularly shocking, I think, with some of the evidence we have heard so far, as well as submissions, is not just the fact that regional and rural health services don't seem to be meeting the needs of the population, but there also seems to have been a deliberate winding back over a number of years or decades of those services. I just point to your submission, Councillor Yanutsi, I said that correct?
Yanutsi, yes.
Thank you. You state in your submission that there is evidence of the deliberate stripping of equipment and medication in Coonabarabran Hospital. You state that the LHD has deliberately stripped from the hospital surgical...
To bamboozle everybody. So the excuse for the surgical instruments would be as follows. Well, we can't sterilise them in Coonabarabran, and Coonabarabran's not a surgical facility, so therefore they shouldn't have this level of instruments, which are basic instruments, instruments that you'll find in any GP practice. Instead, they give us these cheap and nasty disposable instruments that are very hard to work with. So I've had situations where patients have come in with lacerations to the emergency department, and I've literally gone down to my office to bring back decent instruments so I can repair the laceration, or the patient gets sent to Dubbo, or the patient gets sent to the office. It's ridiculous that such a thing has to happen. And the same can be said in many small rural hospitals.
Has the medical staff requested that you be provided with the basic level of surgical instruments when you found out that they were taken away?
Many times we ask, and many times we're told we're not a surgical facility, or we can't. There's always an excuse, and there's never anyone that takes responsibility. This is what I'm saying about the governance. There is no chain of command. It's all opaque, and there's no one ever responsible for anything. This is a really bad governance issue that you have, and you need to fix it. And unless you fix it, you can spend all the money you like, it's never going to get better. And this is why doctors and nurses disengage, because they feel like they're not important, they feel like they're just cogs in a big wheel, in a big machine, and they're not taken seriously. And the patients are the ones who lose out ultimately. You know, at the end of the day, if a doctor, particularly doctors who aren't invested in the communities, have patients that come in like this, they'll just say, okay, get in an ambulance, go to Dubbo. There's no point in me wasting my time or getting stressed about it. And the patient's the one who loses out.
Honourable Wednesday.
Thank you very much. Just back on the point around surgical instruments and the like. It isn't your testimony that there isn't anything in the hospital that can actually perform those, procedures. It's that instead of having the instruments which require cleaning and the decontamination that you would see in, say, a larger facility, you've got the one-time use items that will do the same job. Is that correct?
They might do the same job sometimes, but not all the time.
So even though you have a preference for the use of those ones, there is still those items in the hospital to do the job. Is that it's that they're a single-use item as opposed to a reuse item? Is that right?
There has been a deliberate downgrading of the instruments. You can't do fine repair of lacerations with cheap and nasty disposable instruments. It's just not possible.
Yeah. No,
if I had some here, I could show you, but there are times when you need good instruments to do the more fine work. And sadly, in some of these hospitals, and Coonabarabran's where I know best, they were there once and now they're not there anymore. And it's very silly that I don't think there's any good business case and there's no good clinical case to explain why such things have happened.
I understand that. I just, I guess, wanted to make sure that people understood who are watching this today that there is still the ability to get, say, suturing done at the hospital. That because they may have got the opinion that it wasn't available.
Yes. No. We are not pretending that there is. We are not pretending that there aren't any instruments at the hospital, but what we are saying is that the instruments that were once there are not there, and the instruments that we now have are not as good.
I understand. I thank you for that. Councillor Shields, you said that Wellington could be, in a better position to move ahead if the hospital was better staffed with doctors. Is that?
There's no doubt about it. If you're out advertising, if there was a young family, for example, thinking Wellington is the place to go, they might be skilled parents, which we desperately need. Once they get wind that the Wellington Hospital has only one doctor, they quickly have a different attitude to wanting to move to Wellington. But the biggest concern I have when it comes to that one doctor is, as I said before, we do have a low socio-economic population here in Wellington who can't necessarily get in the car and drive that 45 minutes to basic health services.
Well, I've got some great news because we've actually been to the hospital this morning and we met with all the staff and the management there. They've actually employed more doctors. So we've actually got full-time cover, 24-hour-a-day cover, with doctors in the hospital for 10 hours a day at least.
Were you at a different hospital?
Order. I just think we need to be very clear about what we were told this morning.
Yes, let's.
That's not what we were
No,
told.
let's. I think it's like.
Well, I know the stunt you want to try and pull, but let's make sure that the facts are on the table here. And I just want to make sure.
I think the confusion was between you saying 24 hours and then 10 hours.
There is coverage 24 hours a day, and as I said, there is a doctor in the hospital for 10 hours a day. There are now 4 doctors employed at the hospital.
Listen, that's a proposition. I think it's a bit different from what we heard, but in any event...
Okay.
May I respond to that?
Please.
It shouldn't take the Mayor and the Chamber of Commerce President of Wellington to go around and get 1,200 signatures to embarrass the health service and the government to get those extra doctors. It should have already been there.
No, they're already employed. Anyway, that's it.
Can I jump in?
Sure.
Yep. Just in relation to staffing, I just wanted to get your opinions, and particularly from the interaction you've had with local doctors, and I understand Councillor
Iannuzzi.
you actually conducted a forum with 8 doctors or so, but I'm interested to hear from, in your opinion or from them, why are we having challenges in getting GPs? And I understand that it is a federal issue. However, the flow-on impact is if we don't have local GPs and they go to emergency, if there isn't a local GP available 24/7. In your opinion, why can't we? What can we do more? So I know we've got settlement packages and things, but what incentives can be given to get GPs to move to regional areas or to stay in regional areas?
It's a topic that could take many days to answer properly. Money is only part of it, but money is certainly an important part of it. So let's talk about that first, because that's the thing that you can fix probably most easily and most immediately. At a state level, you've got the settlement package, and it has fallen way behind. It is so far behind now that it's not worth our while, unless we're true believers, to certainly do any VMO work during office hours, because we definitely lose money. And then after hours, we have to weigh up whether the money is worth the massive disruption it causes.
Could you, if possible, just do a bit of a breakdown, or happy for you to take on notice so that the committee has an understanding of what the salary is and what the money is?
So GPs in small towns get 2 funding streams, you could say. You've got your office practice, your surgery, where you get money either through Medicare bulk billing, or the patient pays you a private fee and then the patient gets the Medicare rebate. So that's one stream of income. And then the other possible stream of income is your VMO work, which in New South Wales traditionally is on a fee-for-service basis. So you get paid a fee for being on call and then a fee for service depending on what you do. So if you're not working, you don't get paid. But if you work, you get paid. And depending on the time of day and what's wrong with the patient, the fee varies. So treating an emergency is paid more than treating a basic problem. Getting called out at midnight is paid better than getting called out at 10 a.m. Now, that package has served the state very well, and it continues to serve the state very well. And I do get very concerned when I keep hearing from all sorts of quarters that somehow fee-for-service is failing. Fee-for-service is not failing. Fee-for-service is agile, it's fair, and it can get to places that otherwise would not be penetrable on a salaried or blended payment type system. So that agility and that flexibility is really important. However, there has been a failure by New South Wales Health to engage well enough with rural doctors to address the obvious holes in the package that develop over time as clinical needs change, as the expectations change, as the technology changes. So there's a massive need to do a one-off indexation, I would say of 20-30% at least, to get us competitive again against the locums and against the doctors in the offices. But we also need to address the red tape and the different expectations that technology, in particular the computerised healthcare, has brought. One thing that the rural doctors, for example, have been lobbying for is to have an acknowledgement that when you admit a patient and discharge a patient, there's now a lot of paperwork that's expected of us that wasn't the case 30 years ago when that package was set up. We now have to load all the medications onto the computer. We need to do admission reconciliations. When the patient goes home, we've got to write discharge letters and send them to relevant parties. That all takes time. And you can't expect that the standard fee of a 5-10 minute consultation on a ward round or a basic emergency department patient is adequate compensation for that. So it's little wonder that doctors are choosing not to do the work, because we see this obstinate approach by New South Wales Health. They just say, no, no, no. The default is just to say, no, you can't, no, you can't. Well, of course doctors are going to get upset, and of course they're going to go for a walk and not come back, and that's what you're seeing now.
What's that called? We're going to go around one more time.
Okay, I'll be really quick. I'd like to speak to the two gentlemen from Bathurst. In your opening statement, you said there were 42,900 people in Bathurst.
In 2017.
Yeah. Oh, so there'd be more than that now. So how many people do you reckon are in Bathurst now?
Approximately.
Yeah, approaching 45.
45,000.
Yep.
And your evidence, you said there is no neonatal services in Bathurst. So a community
Is
No,
it
no.
Intensive.
Intensive
ICU.
care.
intensive, because I was going to say to you, neonatal are intensive care for premature and sick newborns.
Correct.
Right? So we're all in the same wavelength here.
Correct.
So what was the population again you estimated were in the town of Bathurst, city of Bathurst?
Now,
Yeah,
about 45,000.
45,000, right?
Yep.
So what does that mean to the community of Bathurst if there's no neonatal services? Do you have a situation where mums and bubs are split up, separated?
Yeah, that's what I was saying. Exactly. If there's a problem in birthing, then the whole family's separated.
So what happens? Does the mum stay in Bathurst and the baby goes to Orange, Dubbo or Sydney? Or what happens?
I think the mother usually goes with the baby, and but fathers, grandparents, sisters, brothers are all left behind. I mean, it should be a time of, you know, happiness and celebration. I mean, if something goes wrong in a birth, obviously it's distraught. But to have the family separated in that time is just not on. It should be that situation. I mean, with the city of Bathurst growing at the rate we are, and we're one of the fastest growing cities in regional New South Wales, then we're trying to attract people to our city. We want people to come and live in our city. But if they find this sort of thing out, and especially young families, that's probably enough to deter them not to come. And in my statement, I did say that, you know, to the demise of the health system could be the demise of our economy.
Thank you.
At that rate.
Thank you. Just to balance it off, a government member would like to just ask one question.
Yeah, well, I've got just one on that, but did you want to?
Yeah, on that one, yeah.
Councillor Orban, do you know how many NICUs there are in New South Wales?
Sorry?
Do you know how many neonatal ICUs there are in New South
I
Wales?
don't. No. I would not know. Do you?
Well, so I used to work.
It's always, just so we're clear, it's you know what I'm about to say, this is a sort of a gotcha sort of thing. You don't sort of set things up quite like that, you know how I'm saying here.
So I was an adult paediatrician and I used to fly for child flights. So I used to come and pick up kids and take them.
Is there a question coming?
Sorry?
Is there a
and
question
so,
coming?
There's 4 NICUs in the state, including Canberra. So places like Wagga, Orange, they don't have them either. So it's such a specialist. It's such a specialist tertiary retrieval centre. There's 4.
I thought Orange did. Sure. Okay, well that's a point made.
That's
Natasha, do you want to?
I've just got a question in relation to
Very
the
quick.
role of nurse practitioners and whether or not you think there could be greater opportunities for recruiting of nurse practitioners in our rural and regional hospitals.
Absolutely. I mean, you've only got to look at you go back to the number of beds in the hospital to the number of beds that are actually in the hospital that are serviced. And we would like to see every physical bed in that hospital serviced, which, because of the number of nurses that are employed in our hospital, there's obviously beds just sitting there unused. And I've actually got a letter here that was sent to me by a doctor from Bathurst. He's a VMO, and which states exactly. I mean, his conclusion was Bathurst Hospital needs more beds, and even at this time of the year, before the flu season's even hit, that the worsening bed crisis it is happening now, and we've got bed block even last weekend. I mean, it's happening all over the state, I know, but to actually be happening in our city, in our hospital, is quite distressing to us. Find that there's operations are being put off because they haven't got beds to put the patients in after the operation. So it needs to improve. We really do need improvement in this situation. It's just rubbish as it is.
Well, Councillor, I'll need to draw a line there.
Mr. Can we table, get a copy of that letter if it's not
Well,
private correspondence?
First of all, just one.
Sorry, Mr.
So we'll finish the question now. We've gone well over. I've given some latitude, given the, dare I say, the high quality of the evidence coming from yourselves as being local government representatives, and in particular with Dr. Anuzi, some particular medical expertise. So that's why I've gone over. So that's the end of the question. Now, there's been a question raised about the letter referred to by Councillor Orban. Now, that may well be something that, you don't need to make a decision on that now. There may be some material in it which needs to be redacted. It might be a private letter. I don't know. The committee secretariat can give you some guidance about how you might, if you wish to do so. Well, we were
looking at doing after this meeting a quick submission.
No, that's
facts that may be missed.
No, so may I suggest that the committee secretary will give you some guidance in regard to matters that might be related. Well, gentlemen, listen, thank you so much. As I said, I deliberately went over. I know not all committee members are happy with that, but I thought, given, and that means it's going to come out of our lunch break, so don't worry. So thank you so much. We could talk for longer, I'm sure, but there is the limit. So there may well be, in fact, I expect to be some questions on notice, and if you're agreeable, the committee secretariat will follow up with questions that are taken notes, but also supplementary questions that may arise after members have read her answer. So thank you all very much, and appreciate the thoughtfulness in both the submissions and the quality of evidence this morning. Thank you very much.
Thank you.
Our next set of witnesses. Thank you very much. I apologise. Yes, I apologise for the lateness of calling you, but we won't crimp your time too much. I undertake that. You're most welcome as witnesses to this inquiry. We have Ms Staggs and we have Ms Gregory-Jones. Thank you both very much. Can I first of all thank you for your respective submissions, and in some instances some follow-up submissions that arose from further information provided. So they've all been processed and stand as submissions to the inquiry, so that's already been done. What I'll do, if can, first of all, just to get you sworn or affirmed into the evidence. So, starting on my left, if you could please just state your name, your position title, that you're here before the inquiry today, and then swear either an oath or an affirmation, whichever you prefer, the words should be before you. So, we'll start with Ms Gregory-Jones.
My name's Samantha Gregory-Jones, and I'm a registered nurse. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you, Ms Gregory-Jones. Ms Staggs.
My name's Cherie Staggs and I'm a registered nurse. I swear that the evidence now given by me shall be the truth, the whole truth and nothing but the truth. So help me God.
Thank you very much. Now, what I'll invite both of you to do is to, if you wish to do so, make an opening statement. I'm wondering, in terms of the opening statement, keep it reasonably tight because your submissions contain the substance of what you want to say, so you don't need to repeat that per se. It'll be most productive if you keep the opening statements reasonably tight, and then we can open up the questioning. Are you happy with that?
Yep.
Okay. So we'll start with Ms Gregory-Jones. Thank you.
My name is Samantha Gregory-Jones. I'm a registered nurse at a small facility in the Central West. I have been working at this facility for 3.5 years and have attained multiple roles. I work in a Class D community hospital which provides an acute service which includes 10 acute beds, 2 emergency department beds and an ambulatory care service. This facility is very old, poorly designed, insecure and includes multiple buildings which are filled with asbestos. The facility was opened in 1922 and has only had minor refurbishments due to the community disagreements regarding its heritage status. As the only registered nurse on duty, I am often working in a separate emergency department in isolation. I am a proud and respected member of my community who believes that just because we are privileged enough to live in a rural area, we still deserve the state-of-the-art care which the system has promised us.
Thank you very much. Very precise, very tight, and to the point. Thank you very much. Ms. Staggs.
Good afternoon, inquiry members. As a member of the New South Wales Nurses and Midwives Association, I thank you for the opportunity to speak about my experience working as a registered nurse in a rural multi-purpose health service. Nurses are vital in providing safe patient care, and I appreciate you listening to my concerns today. The facility I work in has 8 permanent residents, 1 respite bed, 12 acute beds and 3 emergency beds. Nursing staff for these 34 beds are 2 registered nurses, 1 enrolled nurse and 2 AINs for the morning and afternoon shifts. The night shift has 1 registered nurse, 1 EN and 1 AIN. And a security officer is available some night duties, but not everyone. The health service includes dialysis, community nurses, community midwives, an early childhood nurse and an Aboriginal health worker. These positions are not full-time. Our health service manager is working across 2 more facilities, and our nurse manager has no dedicated clinical hours since the health service manager has been shared across 3 facilities. Gilgandra lies at the intersections of 3 highways and is 65 kilometres north of Gilgandra. It services multiple smaller rural towns and localities which have no hospital or medical service. Some years ago, we lost 8 hours of nursing hours in the acute ward on an afternoon shift, followed by another 8 hours on the morning shift a few years later. Once these permanent hours were removed, there were less people to call when needing to escalate for an emergency or an increased bed numbers. This then compounded the ability to take more admissions. If there is no one to escalate to, then we cannot admit and our bed numbers stay down. It has been a downhill spiral. Essentially, 6 beds have been unofficially closed, now known as surge beds. Those 16 hours in the acute ward was an endorsed enrolled nurse and was essential when dealing with an emergency and maintaining nursing care to the acute patients while the RNs managed the emergency. Since this change, 1 or 2 staff members from the aged care ward need to leave their patients to help in ED and acute when we are busy, leaving residents with inadequate supervision and care. The impact of this is further compounded on night duty when only 3 nurses are rostered to work across the entire facility. We recently required staff from other health services to come and work our unfilled shift. It is a big ask to come and work in a facility that is unfamiliar to them. The nurse manager is also often required to attend clinical care to cover the shortfall in the roster. If you can't fill empty shifts or cover sick leave and staff that are already on overtime, who can we escalate to? As a branch, we have requested through our reasonable workload committee an increase in number nursing hours and to change the escalation plans. Our requests were rejected as on paper the numbers do not allow for increased staff from what it is today. However, the rural nurse does many tasks that are not direct clinical care, and I'm not sure this was taken into account. In larger facilities, there are staff employed to do these tasks, such as wardsmen, social workers, pathology, the ordering and unpacking of nursing and pharmacy supplies. We wheel the video conferencing unit around and sit on consultations with a virtual doctor when no doctor is on call. We leave the acute and ED wards to check medications and attend clinical reviews in the residential aged care ward, leaving a nurse alone back in the ED and in acute. After hours, we change the oxygen cylinders over when they run out. We answer every phone call. We replace staff when someone calls in sick. We do all of this on top of our nursing care that is required by our patients and residents. Finally, the supply budget is too low. We often run out of supplies, so we borrow from other health services. We try to use alternatives. We try to conserve where we can safely. Medical supplies like dressings, incontinent pads, infusion equipment, oxygen masks and many more are expensive but are necessary to provide safe and effective care to our patients. I argue that $3.57 per bed per day is not enough to provide adequate care. This could also be said for the community health supply budget. Rural nurses live and work in our communities, and by the end of our shift, all we want is to have provided safe and efficient health care to our patients and nurses and our residents. Increasing nursing hours and the supply budget is some of the first steps in providing adequate and safe care for rural people in New South Wales.
Thank you, Ms. Staggs, and can I acknowledge and thank the New South Wales Nurses and Midwives Association for their participation in this inquiry. Now, just for members' understanding, we'll do 15 minutes each, which will get us to about 15:15. Okay, so everyone gets a fair cut. So we'll start with the Honourable Walter Secord.
Thank you both for what you do. Thank you for your dedication. Ms. Staggs, you mentioned you work at Gilgandra MPS?
I do, yes.
And Ms. Gregory-Jones, you work at?
Canoundra Hospital.
Canoundra, okay. Now, you mentioned, Ms. Staggs, that at your MPS, that you find that you're forced to borrow and ration. You're nodding in agreement too, Ms. Gregory-Jones, both of you are saying the same thing. That you're forced to ration and you run out of incontinence pads. Tell us the things that you run out of.
Most of the emergency and life-saving equipment we don't tend to run out of. We don't need that very often.
Yep.
You know, we need that only on occasion, and generally we have that, we only need it in small numbers. But it's the everyday stuff, like the incontinence pads or the dressings, the suture equipment sometimes. We often, there is what you want is not there. Sometimes we've had to borrow incontinence pads over a weekend from the other aged care facility in Gilgandra, which is not run by New South Wales Health.
Do you have to have medical staff hop in a car, drive there, get them, and then come back?
It's close enough that we walk. We usually meet in the car park.
Meet in the car park?
Yeah. And sometimes they've had to borrow stuff from us at times, but more often it's us from them.
And if you run out of these supplies, well, how does that impact on your patients?
Well, it depends on what we're running out of, but it can be anything. I can give you an example. If one of our aged care residents has a skin tear, which is, knocks the top of the skin off, they need a dressing. The staff will come to their storeroom to find the right dressing. If it's not there, they might come up to the community health cupboard, if this is after hours, and try and raid our supplies. If we don't have it there, which sometimes we don't, they'll find an alternative, but that might delay wound healing. It might then mean that the dressing has to be changed more often, so that can cause pain for the patient, and it means there's a possibility of more infections. So it also just takes longer to look in all the cupboards of all the places that they might be stocked, and you might to get lucky.
Ms. Gregory-Jones, do you have similar examples?
Yeah, so it's a common occurrence for us that we run out of antibiotics, unfortunately.
You run out of antibiotics also?
Yes, so we're stocked by a hospital that is located 30 minutes away from us. We do not have our own pharmacy department. So we do our own stores ordering, which goes to this location and they send it across. So we can only order on certain days. If we, for example, have a patient, and we have a limited stock, so for example, a regular medication we use might be cefazolin. We're allowed to have...
What is that for?
So it's an antibiotic, a very common antibiotic, which you might just use for a general infection or a laceration or anything. Yep. Just 2 days ago, we had 3 patients on this medication, and we're only allocated from pharmacy 2 boxes. So that only lasts us 1 day. So we have to get somebody, we had to contact the RNs at this other hospital and get them to deliver it. Sometimes it might be a nurse from that hospital driving past us who might drop it. Sometimes we've had somebody who is in IGA, who we know is in this location, pop past and grab it for us because we cannot leave the building to get it. Otherwise, if we can't organise a way, sometimes the courier will bring it the next morning at 1 o'clock in the afternoon. Otherwise, the patient misses out, unfortunately.
Now, you mentioned, you used a word in your opening statement. You said that the hospital was also insecure.
Yeah.
What do you mean by that?
We do not have a security guard. After hours, there may be myself as the registered nurse and one enrolled nurse. We do not have a security guard. We have our emergency department is accessed by a swipe card, but everything else is not. We have doors inside the building which you can just walk out the door from inside. They're not locked from the inside. Nobody can get in, but anybody can get out. So we often, whilst we're running the ward, we can have a dementia patient who walks out the door, or a couple of weeks ago we had someone who walked out the back door at 3 o'clock in the morning while 2 other nurses were attending patient care, and there was a very soft alarm that alerted them. He was already out, the patient was out and consequently had a fall. It happens commonly. Anybody can just push the door and out you go. We've had another patient who, during handover, was unsupervised because the patient was in their room having their breakfast, and unalert to us, he was down the alleyway. He just walked out the building while nobody was watching. So it happens.
Now, I noticed there's one thing,
Yep.
that you haven't mentioned either one of you doctors
Yeah.
at any point.
Yeah.
Do you have doctors in your hospitals?
We're very lucky. We have 3 doctors who work with us, but they're on a rotating roster. They are not with us 24/7. They might come in for they will come in for a triage 1 or a triage 2. If there are 3 or 4 or 5, we do most of the treatment ourselves, and then the doctor, a lot of the diagnostics is done via telephone.
By telephone, not even by telemedicine, but by telephone.
Telephone. We ring them and they might say, yep, send them to wherever for an x-ray. You can put the cast on, you can give them this medication, and then they'll ring at the other end, okay, I've got the results, it's broken, not broken. And then, yeah, so we're doing the treatment and we rely on the diagnostics from them who are in their own practices looking after their own patients at the same time.
Do mistakes happen?
I'm sure they might. Nothing too drastic has ever happened. We're all very well-trained nurses. We're all very experienced, and we have obviously great clinical judgment. But it opens a big door of mistakes. It definitely does, particularly when the one registered nurse is also got 10 patients on the ward, plus the emergency department.
Ms. Staggs, do you want to add anything to that?
We're very similar. We've most of the time have doctor coverage,
Yeah.
but there are days and sometimes up to a week where we will have to use the virtual on-call remote doctor through the video conferencing. At night, we, after I think 8 o'clock, we go to the virtual system. So our doctor's not working for a week straight, 24 hours a day. If they're in town, on that day, if we had a triage 1 or 2 and a good emergency,
Yep.
we could call them and they would come. But that's if they're on call and they're in town on that day.
Now, do you, you may have heard, I don't know if you have or not, but previously we held hearings in Deniliquin and Cobar, and there were several examples of support staff at the hospital, tea ladies and cleaners, assisting with patients. Do you find that have you found yourself in similar situations where you've had to have support staff in the hospital support you?
It hasn't happened as often as it sounded like with some of those submissions, but yes, we have. It's actually written in our escalation plan for emergency departments once they've utilised other clinical staff like community nurses or the educators,
Yep.
who are only their business hours, that they may need to use non-clinical staff. So we have had non-clinical staff helping out in aged care or on the ward if necessary.
Have you had similar experiences, Ms. Gregory-Jones?
We have. Fortunately, it's not too commonly occurring, but I would have many examples of it happening. There is one example I would like to share though, where a patient attended the emergency department. He was acutely unwell, but he was also aggressive.
Yeah.
It was very fortunate that it was daytime because otherwise it would have just been an absolute disaster. So that meant our HASA or health, he's got a basic security, what do you call them? A health and security assistant. We don't have a full-time security officer, but we have a health and security assistant. It was fortunate enough that he was on duty that day and came to assist us. But we relied on virtual health to assist us in this incident. Our security officer, or HASA, was himself injured. We had to wait 20 minutes for police to arrive. So unfortunately, we had to restrain this person.
Who restrained the patient? You?
whoever was available. As unethical as that may be, we had to do what we had to do for our safety. The paramedics were with us and the nurses. We just had to protect ourselves. We were put in a very terrible position. We spoke to the virtual health system who turned to the camera, so we've got a camera that they can see what's happening. They watched the incident unfold, and because when the police arrived, they were happy that this patient was secured, they let us wait. They said, that's fine, it's not urgent, you're in secure, you're fine. 5 hours for this patient until he left, which resulted in 2 nurses being taken off the floor, which then meant our administration officer or lady was on the floor answering the buzzers, taking the patient to the toilet. So were the cooks, while the health service manager was called in from another facility to ring around staff to get them to come in early for their shifts because there just was nobody available. So it happens. Yeah.
Thank you.
There's still a little bit of time, so... You can come back for a second bite, but what I'm saying is it'll be the time. You've basically got 4.5 minutes.
I want to go back to the sharing of supplies.
So we won't be coming back now, so we won't be circling back.
Okay, circle.
Righto, okay.
None of both.
Honourable Member Hurst, Deputy Chair.
I want my second bite.
Thank you both for coming today. Ms Gregory Jones, you mentioned, and I'm sort of following on a bit from questions from my colleague, about the insecurity of the building. You talked a lot about the insecurity for patients, but you also mentioned in your opening statement that you're often working yourself in isolation as well. Sort of also flowing on from the example that you just gave, what sort of insecurity is there for staff that are working in these hospitals?
So the only securely locked area is the emergency department. Our nurses' station is not lockable. There was another incident only maybe a month ago where there was a patient who was aggressive and unwell, who forced the staff to go inside the nurses' station. Unfortunately, they couldn't lock the doors. The patient was trying to get through the doors. They had to put some chairs on the doors whilst they wait for the ambulance. They rang the emergency services and they said, I'm sorry, this is not urgent, so it's going to be a 30-minute wait. And in that time, they sat there and they waited. And while this patient was, it's all surrounded by glass as well. So the patient had the blood pressure machine and was hitting it on the window, trying to break the glass. And they just tried to sneak out and lock all the fire doors and seclude this person while we waited. We have asked for swipe access to all of our areas. But that so far has not been approved because the system, the building itself is just too old, it won't support it. So, but it is a work in progress.
And you talked about the example that you gave just before. You said, thank goodness it didn't happen at night. I mean, and what would have happened? It would have been a situation like that with one nurse trying to lock themselves away, or?
Yeah, I suppose the only difference is we wouldn't have had that security member. So at night it would just be myself or whoever and one other person. So there's no security. After 6 p.m, all the cooks and cleaners, everybody's gone.
Are you worried for your personal safety each time you're going to work?
Yep. Sometimes you go to the emergency department door and you don't know what you're going to walk into, and you walk in there by yourself. So I could give you a multitude of examples, but just over the weekend I was just working with my colleague, and we've had 8 patients on the ward. A few of them are rehabilitation patients, so they need to be moved with 2 or 3 assistants. Then I had 4 patients in the emergency department, so I had to leave my colleague, leave my patients, attend to the emergency department on my own. I can't hear what's going on in the ward. When I walk out of the ward, there's alarms going off, which I can't hear in the emergency system, because there's a patient who's trying to leave the building who's got dementia, and nobody's there to watch them. And
wow.
Yep.
With the understaffing as well, and the issues surrounding that, what kind of pressure are you guys feeling on the ground if you wanted to take holiday leave or sick leave? Is there kind of a pressure to
Immense pressure. I can tell you a very personal story. Just this weekend, my 2-year-old boy was burnt. I was a registered nurse who was treating him. I had to watch him be the patient. I was on duty. Nobody else could come and cover. It was 8 o'clock at night. So him and his father turned up at the emergency department. I had to treat him like anybody else when he's just, mummy, sorry mate, I'm your nurse. So I had to do his blood pressure. I had to rip the skin off his wounds, treat him, give him medication because nobody else was there. We didn't have appropriate dressings, so we had to drive yesterday to Westmead Hospital. I was then told I wasn't allowed to be with him because only one parent could be with him. So I had to sit downstairs outside in the cold and listen to him via video, just screaming in pain. And then we had to drive back last night, got home at midnight, and then we were told obviously he can't go to daycare for a week. So I now have to break it to my boss that I can't work for a week, which means somebody else will have to, I don't know, we've got 4 registered nurses, and we're all there, we're all,
You're all got each other's back, but at the same time when something happens, it's just very
So
stressful.
if someone...
You have the same experience?
I've actually stopped taking extra shifts in the emergency department. I have a graduate certificate in emergency and I've been a nurse for 20 years. And I used to love working in the acute ward and the ED. Once I moved from Dubbo to be with my husband in Gilgandra, and I have a young family. Once they started taking hours away, I didn't feel safe and I didn't feel that I could do my job to the best of my ability because I didn't have the backup that I once did when I had that extra nurse. I haven't done a ward shift since last year after one shift that I just felt that I couldn't do it safely and I'm not putting my registration forward anymore. I work in the community nursing part-time and I used to pick up some extra shifts to help when someone calls in sick or when someone's on holidays, and I don't feel I can do that safely anymore, so I've stopped doing that.
Yeah, no, fair enough. And in the association submission, there was a lot of talk about on-call nurses and doctors having to travel a long way to the hospital. Just for the benefit of the committee, have you experienced that as well, where you've had to look for somebody that was far away that would have to come in, and the pressure that puts on the staff while we're waiting for those people to be able to come in and fill last-minute placements?
Some of our staff live over an hour away on properties or in other towns, but we've had to get staff from other health facilities to fill our vacant shifts when someone's called in sick or had an unexpected family member issue that they needed to be off for, and we couldn't cover it with our own casual staff or our own part-time staff. The nurse manager often does her shift and then does an overtime shift, so there's someone that's trained in ED to be there to triage, because not every registered nurse in our facility has that emergency experience. It's a big ask to come from Bathurst or Dubbo and you've never stepped into Gilgandra to just hit the ground running and take over it, and you're in charge of the entire facility, 34 beds. And that's happened...
Without support, because it's already so understaffed? Is that what makes it so hard for somebody to step in? Because sometimes you might be working in isolation?
Yes, that, but also you've got, like for us, we've got 19 aged care residents who have a very dedicated team of AINs and ENs looking after them. They know them really well. They're almost like, they treat them like their own family. But when something goes wrong with them, these nurses are coming in, they don't have any of their background history, and to try and figure that all out in their notes and actually know that patient really well and do best for them, as well as trying to run an emergency department with multiple patients, as well as an acute ward, that's a big call for a registered nurse who works there all the time, let alone someone that's never stepped foot in that facility, doesn't know where the bathroom is. They don't, you've got handover, this is where things are, and they're gone, that's it. And they might have support from one other registered nurse, but that's usually a junior or inexperienced registered nurse.
Thank you.
Thank you, Chair, and thank you both for coming in and giving evidence today, and for the work you do and the kind of frankness and honesty of your evidence, which I think is really important and probably particularly difficult in smaller communities to do so. So really, I'm sure we all. I can speak for everybody saying how much we appreciate that. I just wanted to, Ms Daggs, you talked about a couple of times now, you've mentioned that when the permanent hours were removed or when they started taking hours away. Could you just expand for the committee on what that is and when that was? And we'll start there.
I've tried to find the dates, but I wasn't, I guess, paying much attention. I had young children, I was working part-time, but I remember how it felt when they first decided that, I think it probably goes back to, we had a couple of GPs that were regularly in town and the 12 beds were full often. And once they left or they stopped taking patients and didn't do on-call anymore because they're working down their retirement, our bed numbers weren't full all the time. And that then impacted, they said, well, you're not full all the time now, so you don't need those 8 hours a day. That was on the afternoon shift, so we went from, I'm just talking about acute and ED, this is not residential aged care, their staffing numbers hasn't changed at this stage. It went from 2 registered nurses and enrolled nurse down to just 2 registered nurses, and some afternoon shifts. If you're having a good shift, it's manageable, but if a lot of patients come into that ED, you've got one nurse trying to look after multiple ED patients, or someone that's critically sick, when you really need 2 of those 2 registered nurses looking after that patient, you've still got your other patients on the ward. So sometimes we have to call the aged care staff to come and help us, either in the emergency or on the ward. We struggled with that and we found it okay. And then in the last couple of years, they've now taken that 3rd staff member from the morning shift. And any nurse can tell you that morning shift is probably the busiest shift. People need showers. You usually have to call other health services to arrange transport or, to go to Dubbo for a CT. You're dealing with family members, you're doing their admissions, you're doing the discharge, you're doing the doctor's round, all while ED patients can come in. So that 16 hours a day we don't have now that we used to have.
Because you also said that 6 beds have been unofficially closed at Gilgandra. It's an MPS, is that right?
Yeah, that's right. They're unofficially closed. They've been deemed as surge beds. When I put my submission in, it was 4. So we've got 12 acute beds. They made 4 surge beds, which meant when we got really busy and we had more admissions, we could open them if we had the right number of staff.
You're shaking your head?
We don't have any extra staff to call in. Sometimes we admit over that number, but in the last 6 months, it's been deemed that 8 was too high a number, so they've made it 6. So there's essentially 6 beds there that we try not to use because we don't have the staff to staff them.
So if you had the patients there that needed the beds, you still couldn't use the beds because you don't have the staff? Is that?
Essentially, that's the way it should work, but we're not going to turn patients away. So we might have an extra 2 and we will try to do our best, but it's not ideal and it's not safe.
Ms Gregory-Jones, do you have any comments in relation to the questions I've just asked as well?
We're in a bit of a similar position. So when I said earlier that we've got 10 beds, we are staffed for 10 beds. We've got physically 15, but they're the same. They're surge beds, you could call them. So we are only staffed for 10, but we have physically got 15. In saying that, we will not turn patients down. Sometimes we might have 12 patients. We will escalate. We will use our escalation plan. That doesn't mean we'll get anybody. So it might still be those same 2 nurses working after 12 patients plus the emergency department.
So what reasons have been offered, maybe to you, or what you believe are the reasons that there has been what seems to be a systematic winding down of resources? Is it because there's not the need for it? Ms Daggs?
We haven't really been given any reason other than when they've done their staffing review, the bed numbers are not as high as I guess they once were, so we don't need those extra staff, or those staff that we once had. I haven't really been given an explanation.
Because does it seem to you that you have been, that there's been decisions made to reduce the staffing and resources for some reason, that a clear decision has been made from the government?
Well, this has been happening but over the last 10 years at the most. They've just reviewed and said your numbers are not there. You don't need that staff member. You've got to find a way to work without that 8 hours a day.
And so this is a parliamentary committee looking into, obviously, health services. What would you say now in terms of what you need to make your hospital where you work sustainable for both, for the workers, the people that work there?
I think for our facility, and every facility would be slightly different because it depends on their bed numbers and their setup, I think we need those 16 hours back. But I'd also say we need a 4th staff member in Gilgandra on night duty. And I can give you an example of why. I was a patient on night duty. I don't go to hospital unless I really needed it. I had to wait at the front door for the nurse to come and get the doorbell. There mustn't have been security that night. I didn't see the security guard. That's okay. I knew that would happen. And she came and took me down to ED. There was 2 other patients there. So she had 3 patients in the emergency department, plus her ward, acute ward. The other 2 staff members from the aged care facility had to come and help her triage, do OBS on me and the other 2 patients that were there. And then we got seen by the virtual doctor. They were frantic for that hour until I was stable. And they did a wonderful job. I felt I got good care. But I don't know who was looking after the other patients. I couldn't see that. They were there with me and the other 2 staff the other 2 patients in ED.
With the aged care, for example, nobody was looking after them, were they?
Someone probably came for 5 or 10 minutes and they may have not been, and then one would have gone back, but then they're working on their own. And if they didn't come and help this nurse, she would be on her own looking after emergency patients and the acute patients as well.
That's it. We're all getting about 13 minutes, so government members, who would like to start?
Thank you very much for coming in today. And Ms Gregory-Jones, that you've gone to Westmead and then back and then come here today is phenomenal. So thank you so much for doing that. It's really really appreciated by us, and I hope your son's going to do okay. I just wanted to talk about I guess the supplies issue, and is it about like a delay between the ordering and the delivery? Is it or is it issue of timing, like you were talking about with the pharmaceuticals, where they need to do deliveries on certain days? What is it you think that we could do that would actually assist in making sure that we've got the required stocks in and at hand?
I can answer. You're right.
I think it's difficult because some days 2 boxes of an antibiotic is fine, but the next week it might not because 3 people who need it come in. So it's a really difficult thing. But the fact that we only have a pharmacy 2 days a week on a Monday and a Thursday means that we have to be very forward in preparing but we can't predict the future. So it's very difficult.
There's two issues. One is logistics, because if we order on a Monday, we might get it by Friday. Sometimes it might miss the truck, or I don't know what happens, and we might not
get a delivery.
Twice a week on Tuesdays and Fridays.
And where does it come from?
I think it all comes from Sydney or Orange. Yeah, so it depends probably on the item. If it's a normal supply, it's a bit quicker. Sometimes we have to order stuff that's non-stock for more specifics. thing. So that's one issue. The other issue, I've done the ordering for the hospital for the nursing supplies before, and I had to cut my order down. I always did the full order, and then every time I have to cut it back to the budget. One time I had to cut it back by over $1,000, and I would have liked the stuff that I'd cut off. I just had to reduce the numbers. So we got a bit of everything, but probably not really what we wanted. And it ebbs and flows. If I've got 6 patients one week, but I've got 12 the next week, the budget's the same.
Yeah.
So, you know, one week maybe we're not going to run out of things because we've only had a very quiet week and there hasn't been patients with multiple drips. Like, it depends on what's wrong with the patients, how much equipment you're using.
Yeah.
The aged care facility mostly is pretty standard, probably.
Yeah.
But they don't always get the right dressings. Community.
So they deliver the wrong ones? Or
No, sometimes the ones we need are not there. They're not the most appropriate or best practice. And community health, the community health budget, we're always running out of things. You're probably finding the same.
Yeah.
So it's not so much an issue really of delivery and timings. It's being able to predict what items you might need into the future with the patient care that you've got to provide.
I think we can probably predict mostly what we need because it tends to be most of the time it's the same things, but it's when are we going to need it? If I don't have a burn this week, I have a bit of supply there in case we do. But if I've used that up and I end up with 2 or 3 patients with burns, we're going to run out, and if we order, there's that delay. So we'll try and find something else, or we'll borrow from another facility like Coonabarabran or Galar or somewhere else,
No, I was just trying to, obviously, you know, it's our job to make sure we, I guess, report back and provide recommendations. So I was just curious as to how you thought we might best actually be able to tackle some of these issues. But, thank you very much for your insights. I know my other colleagues have got some questions.
Honourable Luamato.
Well, I'll start by thanking you both for the great work you both do. For the benefit of the committee, can you tell us about the level of palliative care, right, and particularly in relation to pain management?
I do quite a bit of palliative care in my community health. I look after the patients at home until they need to come into a facility. So I deal with the GPs, their own GP, to do that. But in the hospital, we have 1 palliative care bed. Mind you, all the residential aged care patients, if they were at their palliative part of their life, we would just nurse them in the bed that they already have. Pain relief for palliative care patients, it depends on the doctor prescribing and the ability for the nurse to advocate on the patient's behalf whether their pain relief is managed well or not. We've got access to palliative care services. They'll do a review and recommend changes in medications if things aren't working. Has that answered your question, or?
Yeah. I was wondering how the level was out there, whether people will go without.
I think most of the time we provide good palliative care, but we do have some difficulties with doctors, especially if you get locums that are maybe not comfortable with ordering strong narcotics to help people's levels of pains and agitation.
I asked the question because it's in relation to some of the other things you're short of, some of the other supplies you're short of. I was just hoping that wasn't the same case in relation to the pain management of those in palliative care, that's all.
There's been times when we've had to, if someone's been on really high levels of pain relief medications, that we've had to get a staff member that was shopping in Dubbo pick up some supplies from the pharmacy there to bring out so we've got enough. So that happens from time to time. Yeah.
Thank you very much.
Thank you. I've just got 2 questions. One relates to nurse practitioners, and I'm a former nurse, so I'm a big fan of them. And I asked the previous witnesses in relation to nurse practitioners, and one of them actually indicated, yes, there is a greater need. I'm interested in if you could just elaborate on one of your recommendations, which is about seeing an increase in nurse practitioners, particularly in rural and remote areas, and how that would work.
I think it's an absolute necessity, and me myself would love to become one of them. That's one of my inspirations. As I mentioned earlier, a lot of the nurses, so we're FLEC trained, so we've got first line emergency care courses, and a lot of the treatment, because our doctors aren't available, we're giving that treatment and just relying on the diagnostics. So I think it would be financially very beneficial for the government to be employing nurse practitioners instead, because we're actually there, we're there on the floor, we're not at our own practice down the road. I think it's also great for the community. There would be the potential to run clinics for minor things as well, which would take the pressure off the GPs as well, because there is no capacity for more patients in the clinics at the moment. And with the population growing and people are moving a bit further west, we are seeing a bit of an increase in the need for people to find GPs, and unfortunately that means more emergency presentations for simple GP things.
Are there any challenges that you see relating to having nurse practitioners? Ignoring the fact of placements, but beyond actually saying this position is reserved for nurse practitioner?
I guess finding people who actually want to come out and do it, and the education, like if they would have to travel to Sydney or things like that.
And also, I think that nurse practitioner would have to be on top of the nursing staff that you already have.
Yes.
And
that's right.
that would be replacing the doctor. If it's hard, if you can't get doctors, could we get nurse practitioners? It'd be nice to know we could. But
The other one is just in relation to your first recommendation about Aboriginal community-controlled health services. And increasing access for Aboriginal people. I just wanted to know, ask you to elaborate a little bit more on what do you mean by having it community controlled? Happy for you to take that on notice if you want.
Yeah, I'm happy.
I haven't put that in my submission. That's probably from the Brent Union. We'll have to take that on notice.
That's fine. That's no problem at all. That's it.
Sorry. Still got government time. So we're being scrupulous about this, so you've got about another...
If you go, if you've got questions.
About 3 minutes.
I guess I was going to ask briefly about the pharmacy. Is it, if you do need something, say, urgently, is there a method of, say, transporting... Apologies. Sorry, Hansard. Is there a method of transporting stuff urgently to you from where the pharmacy is located? Where is it?
So our closest is in Cowra. So that's 30 minutes away. Our second option, so after hours option, is Orange. Our emergency system is we wait for the courier, which comes the next morning. That's it.
Okay. And other than, I guess, the antibiotics issue that we've covered, do you tend to run out of much stuff at all, or is it you pretty well stocked normally?
I think we're pretty well stocked. We do have quite a good range of pharmacy. It's more the patients. We only have a limit, like, when I say we're broad, we have a lot of stuff, but very basic stuff. So any specific medication that people are on, we don't have. So, and including insulin, we do not provide insulin. So it's the expectation that patients bring their own. So sometimes a patient comes in with a medication that we don't stock. It's a basic rule that if they're being transferred for a different hospital during our handover, we will ask them, can you please bring some, this medication because we don't have it, and it's Friday night at 9 o'clock. We can't get it till Monday.
And SA drugs, there's two of you that, like, so you do the checking between the two of you? And then there is always the two so you can actually, I guess, if they're written up for those SA drugs, you're actually able to give them, and there's been no issues with that?
That's fine.
I think the issue sometimes is time.
Yeah.
If there's only 2 of you on, and it takes 2 of you to go and get this drug, and it's not a very quick process. You still have to do the checks and balances. They're both in the pharmacy doing that. Who's looking after the patients? And that could be said when I've got an emergency patient who's going to be ventilated while we wait for retrieval, who need S8 medications.
When you say ventilated, do you do intubated?
I don't do intubating, but if the doctor has, but they need countable drugs to do that process.
Yeah. So you'll have a doctor there as well then, presumably, as well as...
Yeah. Or if we needed to even if I needed to give them morphine for their fractured leg, I have to leave that patient and walk 30 to 50 metres up to the pharmacy and find another staff member to come and check it with me.
Yep.
And the same could be said in aged care, which is through another door when they need their pain relief for their regular pain or their breakthrough pain or their palliative care type pain. I have to, because there's no registered nurses there the majority of the time, I have to leave the acute and ED patients to go and administer that. And at 8 o'clock in the morning, the round, there might be 5 or 6 of those patients needing 5 or 6 different medications. I'm over there for half an hour.
Yeah.
So we might not always run out. In our residential aged care, patients' medications come from the local pharmacy.
Yeah.
So we have to arrange scripts. So sometimes we run out of things because the script hasn't been done and we have to chase the doctor to get that done, and then it has to come up from the pharmacy.
Okay. So the doctor hasn't actually written the...
So they've done the medication order where we administer it, but they haven't actually written the script like you and I would get for antibiotics. So there's 2 systems, one for aged care and one for the acute. So they're done differently. Okay. So that takes a lot of time to manage and make sure we don't run out of those scripts and medications for those patients.
Yeah, but one second.
Ms. Gregory-Jones, I just want to get this correct. So which MPS are you employed at?
Canandra, we're not an MPS, we're an acute service.
You're an acute service. Now, you mentioned that you said there's no insulin at your...
Yeah, we have insulin pens, but it's an expectation of the pharmacy that we don't routinely stock them. We'll have to order them specially. And due to patient safety, it's basically bring your own.
So you have to order insulin or BYO insulin?
Correct.
Wow. Now, Ms. Steggs, in your earlier evidence, you talked about the difficulties of ordering and things like that in budgets. So if you were properly funded, then you wouldn't have to cut corners and you would have supplies. Is that correct?
Yes.
Does the same apply to you, Ms. Gregory-Jones? So that you're forced to cut corners on what you order and supply because of what you order in for the patients because of budgetary constraints.
Yeah.
Can I ask you one last question, Ms.? Sorry, Hansard has to record that. So a nodding is, you have to say yes or no.
Yes.
Yes, thank you. I'm sorry about that. Because they're doing a transcript of this. The last thing I want to do is, you spoke earlier about being called upon to do things in your service and that. Do you find that you're doing things that you never expected that you would do as a nurse, that you're called upon to do?
What do you mean called upon?
Well, I guess procedures or treatment or pain relief, things that you were, I'm sure I can tell that it's a vocation and you want to continually upskill and get better so you can provide services. But do you find that you're doing things that you never expected that you'd be called upon to do?
Oh, yes. Sometimes it's 9 o'clock at night and I'm assisting with an X-ray or I'm putting casts on, or I never thought I would be doing those kinds of things.
And why do you find yourself in that situation? Because there's just not enough staff?
Because there's nobody else available to do it, and for the patient's benefit and the patient's safety, we will do whatever we can to make sure that they get the best treatment. So for them, sometimes, one of our medical officers is able to X-ray, so we only have X-ray 2 days a week. But sometimes, if it's a small child, to prevent them having to travel the 45 minutes or an hour to Orange, we will do it after hours. But it's myself or the doctor or whoever's in charge who will be doing all those things.
I think you need to remember that not everybody can travel 45 minutes to go and get a cast on or an X-ray. Some people don't have cars or the money for fuel, or they've got 3 kids and no support. So how do they take the injured child and 3 others to an emergency department? And yes, sometimes we could organise an ambulance or hospital transport, but they've got to find their way home at the other end.
And
So-
organising things like ambulance, putting them on the portal, doing all the administration
Takes
stuff.
time.
I did not see myself doing.
Do you find yourself also personally supporting people, doing work? that you need?
Definitely.
Like social work, that kind of stuff?
Definitely, yep. We don't have, we've got a social worker who works in our town, I think once a day. She works so off-site, so in the community, so we don't have social work services or things like that, so we're doing lots of extra roles.
Thank you for your time and thank you for your help today.
I've just got one quick one. Mr. Staggs, you're talking about the palliative care and specifically about pain management. But of course, palliative care, particularly at the very end of life, is much more than pain management. It also deals with medication to deal with anxiety and distress. Were you also encompassing that in your comments about palliative care? In other words, medication beyond basic pain management, in other words, the other types of medication, or in fact, that other type of medication to deal with distress and anxiety isn't available and it really is just dealing with pain management?
No, it's not that it's not available. I find it harder with palliative care to what I would perhaps recommend for symptom management, because sometimes it's not dangerous drugs like pain relief, sometimes it's other symptoms like breathlessness or anxiety or urinary retention. There's lots of different symptoms that some doctors are very good at it and some doctors are not sure about it, but they're willing to take advice from us or palliative care services or other doctors, and sometimes we really struggle with other doctors to convince them that this patient is in pain and does need more than what's been ordered at the moment. But they have there's rules around ordering these medications, so some of them are a bit more reluctant, and I think we give great palliative care at Gilgandra. I think the struggle is just trying to balance with the doctor's either experience or knowledge and what we want for our patients and what the patient wants and needs.
Yeah, no, there's a lot to put into balance there, yeah.
So it's not particularly that we're running out, it's just trying
to
go.
No, I wasn't just about running out, but I'm doing you mentioned quite specifically pain relief. I was wondering about the medications to deal with the other aspects of anxiety and distress and the like. Well, listen, thank you both very much. It's been very enlightening, your evidence. It's been great to be able to ask you questions to elucidate what was in the submissions, and we thank you very much. And we thank you greatly for the wonderful work you do. Nurses very much are at that coalface, to use a cliche, and your examples today just give us very deep insight into just how close to the coalface you are. We'd like to thank you very much for the wonderful work you do for communities. Thank you very much.
Thank you.
Thank you.
Yeah, so we'll now conclude this part of the hearing today. So we'll cease our transmission for the moment and we'll be returning after our lunch break, which will bring us and watered one way or the other. Delicious sandwiches and what have you, so it's very nice. So we welcome a number of witnesses this afternoon in our first session after lunch. A number of individuals who can bring some very first-hand knowledge and information regarding matters health and medical services in and around the area. So I need to get through the formal part of the swearing or the affirming in of the witnesses. Can I just say, please relax, okay? I mean, I know this probably for, if not some, all of you, your first parliamentary hearing. Please, we're all friendly, so to speak. Some people are going to ask you some questions. In fact, many people will. So just ask your questions and answer them best you can. But I'll go to that in a moment with you in a bit more detail. But you're more than welcome, and we're very pleased to have you along this afternoon. And thank you for your submissions and making yourself available to come along this afternoon. It's much appreciated. So what I'll do is, starting from my left, Mr. Sundell, we'll get each person to state their name, their position whatever position you hold, or if you're appearing by yourself or by yourself, but your position title, if you're with an organisation, and swear either an oath or an affirmation, whichever you prefer, and the words of both should be there before you. So we'll just start with Mr. Sundell and we'll work our way across. So, welcome.
Yeah. My name's Harold Rodney Sandell.
Yep.
I'm representing Rotary Club of Warren, and I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth. So help me God.
Thank you very much, Mr. Sundell. Ms. Campbell.
My name's Alison Campbell. I'm part of the Warren Health Action Committee and here with Rotary regarding their submission.
Thank you.
I'll take an affirmation.
Thank you.
I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you very much, Mrs. Campbell. Doctor.
Hi, I'm Kitty Eggerkin.
Sorry, the camera was in the way. I'm just sort of looking over and under behind you. So, welcome, Doctor. Yeah.
Kitty Eggerkin. I will take the affirmation.
Thank you.
Solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you very much, Doctor.
I'm Catherine Pearson and I'm taking the oath.
Thank you.
And I swear that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth. So help me God.
Thank you, Mrs. Pearson.
I'm Sherelle Fellows. I'm one of the 3 Golgong petitioners here today, and I'll take the affirmation.
Sure.
I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you very much, Matthias. Well, having got through the formality there, and that's all been done nicely, thank you. We'll offer an opportunity. I should say just for the record that with respect to the respective people here at the table, there's been a number of submissions that have been formally made to the inquiry, have been processed, and stand as submissions to the inquiry. Now, Mr. Sandell, yours is is submission number 97. You would be aware of that.
Yeah.
Dr. Eggerkin, your submission is 183. Mrs. Pearson, your submission is 190. And Ms. Fellows, your submission is 225. So you can take it that those submissions have been read by all committee members. So in making your opening statements, which I'll invite in a moment, there's no need to go through in detail what's in your submission, but perhaps rather set up an overview and some of the particular salient points that you'd like to make, and then we'll open up for questioning. So are people happy with that? So I understand, Mrs. Campbell, that you'll be making the opening submission, and that's effectively a joint opening submission. But okay, so
Correct.
If you could make that, that would be great.
On behalf of Warren Rotary and the Warren Health Action Committee, thank you for the opportunity to speak on one of many health issues in our community of Warren. We're located 550 kilometres northwest of Sydney and 125 kilometres west of Dubbo, which is our nearest regional centre. We have many gaps in our health services that seem to be getting wider. Some 2 years ago, with the support of our federal member and the Warren Shire Council, Warren Rotary took a lead role in trying to establish a 10-bed dementia-specific unit with a respite facility within the Warren Multipurpose Health Service. To date, we've had very little success, and Rotary's lead role has now been taken over by the Warren Health Action Group, strongly represented by many stakeholders in our community, including the Shire. Dementia is the single greatest cause of disability in older Australians and accounts for 52% of all residents in residential aged care facilities. It's the second leading cause of death in Australia at present. The Warren community fundraised and built Kalara House some 25 years ago as a low care facility with the emphasis on creating a home-like environment. It later became part of the current MPS with a written agreement at the time that there would be no loss of amenities to the existing and new residents. With the introduction of ageing in place by our federal government, Kalara House is now attempting to cater for high care residents, which it was never designed for. It is not a dementia-friendly environment, and this makes it more stressful on all the residents and the dedicated staff that work there. Our request for a dementia-specific unit is not a suggestion that we create a separate area and lock the more confused residents away. Rather, we are asking for a purpose-designed area in the MPS that allows more security, more privacy, and at appropriate times, more interaction with the other residents. Warren's population, aged over 65, is greater than the state average, and our median population is 5 years older than the state average. By 2025, it is estimated that 318 people per day will be joining the population with dementia in Australia. Warren needs more residential aged care beds, and they need to be of a smaller care environment and dementia specific, as this has been proven to increase the quality of life, reduce rates of depression, and reduce hospitalisations for people living with dementia in residential aged care. Frail elderly residents also need to remain within their community with their extended families. Sending residents to Dubbo or elsewhere is not a viable option for these people. It causes great distress on the resident and their families in the most vulnerable stage of their life. They have spent a lifetime giving to their community and deserve to remain living within their communities. Warren is a can-do community, and as we've done many times in the past, would support the development of a dementia-specific unit with a respite facility. The local CWA have time-barred funds available for our ageing community, and action is needed now. We have to also change the way we are attracting and upskilling our local health and aged care staff if we're going to staff this unit. We need greater communication and cooperation with our local health district because the current model isn't working for the Warren community.
Well, thank you. That's a very clear and precise opening statement, and I'm sure will be the basis upon some questioning from some of the committee members, so thank you. Doctor, would you like to make an opening statement? Sorry, this camera is in the way, I've got to wave to you. So,
I'd better make it clear at first that I'm not a medical doctor. In fact, my only experience of hospitals was as a young woman being a psychiatric nurse. Which then meant that all doctors in hospitals were salaried employees of the government. I came to Gulgong 2 years ago and went to the local MPS and said, "What do you offer?" And they said, "No, we don't have many services here. You're in the bush now." In fact, get used to it. Don't speak out.
Can I just ask, with respect to the Gulgong petitioners, which include the three of you, is it going to be, what was your discussion between yourselves? That would be a single opening statement that you would make? Because if you're from the one organisation, it'd be very unusual for us to have three opening statements
given that the other two have put in their own submissions, I was presuming that each would make their own submission.
Well, no, that's a fair point. That's a fair point. They are separate submissions, but can I just say, in light of the fact that, I understand the point you're making. So each will be provided with an opportunity, but given there's a degree of overlap, I would have thought you could just bear that in mind. That's all I'd say. So please proceed.
Well, I'll be very brief.
No, take your time. Take your time. I don't want to rush you, but just bear that in mind.
No, that's fine. Unlike other country towns, Gulgong at least is fortunate enough to have a medical practice with 2 GPs. But for more than 3 months, our MPS was without a doctor. And so Sherelle and Kathy started a petition, and that, along with some media attention and the terrible death of Dawn Trevor, eventually led to a new contract for the previous VMO, our local GP, Dr. Yaya, to be reappointed. We're lucky to have Dr. Yaya, though we don't believe that the arrangement is sustainable. How can he continue to run his busy practice and be on call at the MPS remains to be seen. In the past week, cracks have begun to show. If an outburst on the local community Facebook is any indication. In our opinion, the current VMO system is unworkable. We believe that there should be at least one full-time doctor at every MPS whose salary is paid for by the government. On another matter, we three would be willing to serve on the Gulgong Health Council if the terms of membership were changed. At present, members are forbidden from speaking out, which therefore means there's no point to be a member. That's all.
Thank you very much. Mrs. Pearson, would you like to make an update?
Well, I'm a petitioner, but I also sent an individual submission. I'm a community member. We have a business in the main street. And when we started our petition, we dropped it off up outside the IGA every morning. That was my job. And we followed it with a submission box, I'm sure you've all read, inviting people to tell of their experiences with telehealth at the local MPS, because we were very concerned. We didn't want the staff down there to feel criticised. It was a very, very difficult line to tread. But that box went up after our petition closed, and because I took the box up every morning and got it back at night, so many people were stopping me in the street. I could hardly get a few steps. They were telling us about their stories. And so I'm glad we've got three voices here, because we really need to be telling these stories. The difficulty we found was, along with our petition, we were lobbying members of Parliament. We were writing letters to the health department, to our local health district, and we kept coming up with resistance and the message that everything is fine. Everything's great with our system. Now, we started our petitions in September, and on the 25th, I got a letter back from one of the directors of health in the southern section. I'm a little bit unsure of her title, saying we have had no adverse results from the use of telehealth in the Gulgong Hospital, but we had documentary evidence to the contrary, and sadly that was after a local community member had died there with just the telehealth doctor. So to say there are no adverse, I actually printed it out, no adverse outcomes related to the use of the VRGS at Gulgong wasn't true. So we've found this and up until the present time, that has been the line that the health district people have taken. And only a couple of months ago, Sherelle and I went to Dunedoo. They're not in our local health district, but it's a very close town. They were having a public meeting, and it's not easy to get people to go to a public meeting in a small town unless they're really fired up. And they were. We sat in as outsiders, but we were there to support. And people got up and spoke. It was heartbreaking. And the panel consisted of two doctors, one doctor with a vested interest in telehealth, another a person from the local health district based in Dubbo. They didn't take their stories on board. They just, to a person, they responded to that community meeting with, everything's fine. You are so lucky here. You've got a great little doctor. She was there 16% of the time. For the entire week, one man worked out, he got up and said she's there 16% of the time. Now, she went on maternity leave in May. I don't know what's happened up there to replace her. But these people's stories were so bad, we couldn't believe that nothing had happened between the time we started our petition and this public meeting, that everything was still the same. Nobody was admitting that there was a problem. And we'd sent off our letters, we'd sent off these submissions that were put in the box, and I got a letter back from the acting CEO of Western Health saying he described our accounts as unjust, inaccurate and uninformed commentary. We were insulted, we were outraged.
Who said that?
True stories.
Who signed that letter, or who wrote that letter?
The acting CEO of Western Health.
Do you have a copy of that letter?
18th of November.
What's the person's name? Who was the person?
Sorry?
What's the person's name?
Am I allowed to say his name?
Yep. Yes.
His name's Mark Spittle.
Okay. No, that's fine. I mean, I'm not familiar with the gentleman's name. That's why I'm asking you, but that's fine. That's fine. So that's the correspondence you received. What's the date of the correspondence?
The 18th of November. And interestingly, 4 days later in our submission box, we got 4 hate letters, our little group, on Health Department letterhead saying that we, anonymous letters, no less.
But on letterhead?
3 on letterhead, 1 handwritten in a very childish script saying, we're proud nurses down at this MPS. You are undermining us. We feel very unsupported. We knew that this was a concerted effort by someone we didn't know who to undermine our efforts to improve the healthcare in our town. So, you know, it was almost unbelievable, the blank wall that we kept coming up against. But there is a real health crisis. Golgong, we only see Golgong, but no, we see further than that. We see it's New South Wales wide. But our anecdotes are based on what we've seen. And sadly, 6 weeks ago, my husband, in the middle of the night, was struck down with excruciating pain. He's here now. I better not go into too much detail.
No.
But
no need for that.
knowing what I knew, I was very worried. Like, do I ring an ambulance? Where's it going to go? We knew there were problems with them having to go to the nearest MPS. So I rang the hospital and I got a nurse or...
Sorry, you rang which hospital?
I rang Golgong MPS.
Yep.
Sorry, I call it the hospital. And I got it would have either been the RN or the enrolled nurse who helps her, because we only have 2 people on at night and they're stretched to the max. And the fear in her voice was palpable. I hardly got my sentence out to say my husband has severe pain. She said, don't come here. She said, put him in the car and go to Mochi. We don't have a doctor here. Okay, so that was quite frightening. And that's why we're here, because people are scared. I was a bit scared. I mean, I could drive to Mudgee, but a lot of people can't. And I don't like to see that fear, and that's why we're here, because we had to keep pushing right to this inquiry to get our voices heard. So we're really happy to be here, and we're really glad that you're listening, because our health system is in crisis. And please, we don't want to hear that everything is okay, because it isn't.
Okay.
Thank you.
Well, thank you. Now, Ms Fellows, you'd like to make an opening statement? Or would you like to open up the question?
I might just burble. No, I would. In a nutshell, we're here because the situation in Golgong was due to a contractual dispute with the doctor who was in the town. The constant narrative from the health department has been attracting doctors to rural and remote communities is a challenge. In our case, our doctor was there. We sought to understand why that contract hadn't been renewed. I have it in writing that the issue was about the provision of affordable services. We then heard that Coolah also had lost their doctor who'd been there for 7 years. And again, it was reported on the ABC that it was about the provision of affordable services. Trying to establish what the contractual dispute was very, very difficult, because we were told that things were commercial in confidence. I actually wrote, as I was advised to the local area health manager, actually Sharon Mackay, and I said, I write to inquire why the contract with the doctors at Golgong Medical Centre was not renewed with the Golgong MPS. What were the terms of the contract that were so unacceptable? This has resulted in this service being without a doctor now for months, and it is simply not satisfactory. There's widespread community concern about the situation. The virtual generalist service is no substitute for a hands-on doctor. While the nursing staff are doing a wonderful job, the situation is untenable for them. Please advise what steps have been taken to expedite the appointment of a doctor. And the constant response we got to that was that they had advertised and no one had applied. And this goes to the heart of the matter, I think, that the rural settlement package and the whole model for how we staff rural and remote areas needs revision. Kitty and Kathy have already mentioned the Queensland model, where they have a senior medical officer permanently appointed to these smaller centres. It's smaller centres where it's particularly a problem. And also, Mark Coulton, pleasingly, you are probably aware, announced the other day that, and you probably heard Dr Iannuzzi speak to this as well, that the federal government is going to recognise that, that they're going to offer an increased Medicare rebate based on a sliding scale of remoteness. My point is, the New South Wales government needs to do something similar in rural health scholarships, so that we do not have as rural health scholarships that people are trained to at government expense and then end up working in large regional centres such as Coffs Harbour, Byron Bay, etc. The money needs to go where the real need is, and is out here in the smaller centres and more remote areas, because we had to fight. And we have voices, but there are many disadvantaged communities who do not have voices, and people should not have to fight for healthcare, which is a basic human right.
Okay, no, thank you. That's a very, very passionate and strong opening statement, so thank you for that. So we'll open up for questioning now. It'll be roughly about 7-8 minutes each grouping. So we'll start with the opposition.
Thank you, Mr. Chair. Doctor, thank you for all your time, your submissions, and your opening statements. Dr. Kitty Egger King.
Kitty is fine.
Okay, Dr. Kitty. You're a doctor. You're a PhD, so you mentioned in your opening statement, quote, that cracks are beginning to appear. Cracks are beginning to show. Sorry, that's what I meant to write. What were you referring to?
Just in the last week, on our Gulgong Community Facebook page, there's been a whole slew of comments about our GP. Some of them have been supportive, but many have been quite nasty. I don't think it's worthwhile talking about, you know, people on Facebook are anonymous and they just vent their spleen. Some of it can just be dismissed as far as I'm concerned. But it is an indication that perhaps the doctor is being stretched in too many directions.
Okay, now, in your opening statement, you said that when you talked about the lack of services and the response that you received, that you were in the bush now. I'd actually like to get a response from your two colleagues. You nodded, Ms. Fellows. How do you feel about that people are saying you live in the bush, accept it?
I think I've made my views pretty clear on that, really. I think we should have adequate healthcare. And if you've read my submission, I was terribly fortunate. I've lived in Gulgong and worked in Gulgong for 37 years. And we had the services of two very dedicated doctors who staffed that hospital 24/7, 7 days a week. And I am just so grateful that when my children were little, that service was there. And it was a full hospital. It wasn't a multi-purpose service, which is, in effect, and I know others will speak about this, a reduction in services. It's not acceptable. And to take Kitty's point further, the reason why our doctor is under so much strain is back in November, Western Area Health said they would advertise for a second VMO at the hospital, but all they're offering is a standard fee-for-service rural settlement package. So, of course, and I have had discussions with our local member about this quite recently as well, no one has applied because it's not an attractive enough option. And that's the reality, to come out relatively unsupported and accept that package.
So what's been the impact on the doctor and the nurses at the MPS?
They're pretty well stretched to their limits, I would imagine. And I might also add that it was very difficult for us to establish exactly when the doctor was in attendance and when we were reliant on telehealth. So I think my understanding is that from 8 to 6, Monday to Friday, the doctor is on call. And then for triage 4 and 5, possibly he can be called on weekends. So it's still not a 24/7 coverage with a face-to-face doctor.
So what do you do when you have a major health incident? Do you just decide that you're not going to go to your MPS, but you're going to drive somewhere? What goes through your mind? Ms. Pearson? Mrs. Pearson?
Well, fear, basically. Fear and wondering the best way forward. What's the best thing to do, the best outcome? You know that the community knew that the doctor wasn't at the NPS for, several months. So a lot of older people, we hear them saying to their relatives, well, just don't take me down there. They still don't know the doctor's VMO rights have been re-established. But then in my husband's experience, I was told there was no doctor there. So you're sort of caught, really. You don't know what the best thing is to do.
How did you feel when the nurse said to you on the telephone when your husband had acute pain, don't come here?
Look, I wasn't surprised, and because of our campaign, I guess. I wasn't surprised. I was confronted, but not surprised. The next day, my husband was admitted to the hospital, and that very night, the two nurses who were on were recording measurements of a particular hormone in his blood that indicated he could be about to have a heart attack. And so they were taking these measurements and sending them through, I think, to the telehealth doctor in Dubbo, who said, well, look, I want to see those readings taken throughout the night. Now, I left my husband at 8 o'clock in the evening, and when I went at 8 o'clock in the morning, not one reading had been taken, and they were supposed to have been taken 2 hourly through the night. The two nurses said we didn't have time. They were too stressed. They were running. Even when he was there and I was with him, the RN was trying to do the measurements of this hormone, and her assistant was standing to the side, making faces like, I need you down in the other part of the hospital. There are only 2 of them. There are the aged care, the acute beds, and whoever comes into emergency. So they're frightened.
So 2 nurses were in charge of how many patients?
Look, I wasn't sure. We were the only ones in emergency. I know there were a couple in the acute, but there are 6 aged care as well. I don't know what was really happening behind the scenes because it's locked off. But yes, those 2 are expected to cover the whole area.
So what did, you were 3 strong individuals, so I know that you can put your case forward and stand up for yourselves. I get that very clear impression. So, but what about other people in the community? Well, Ms. Fellows, would you want to comment on that?
That's why we started a petition, because they didn't have a voice, basically. And people really did support that petition. And also, Kathy's already mentioned how we had a box where people actually put, we didn't accept any anonymous statements. They all had their name on it. When it came to putting them in that huge appendix that we've sent in, we did say, do you want it anonymous then? But we knew who they were, and they wanted their stories told, but they perhaps didn't have the confidence to do that themselves.
Thank you. Ms. Hurst?
Yes, the Honourable Member Hurst, the Deputy Chair.
Thank you, Chair. I've just got a general question for the Gulgong Petitioners Group. The case of Dawn Trivett obviously highlighted some of the serious problems when we... sorry, can you hear me? Yeah. It highlighted some of the problems with a major over-reliance on the telehealth services. Do the local people feel safer with a doctor reinstated now, or is there a continued nervousness about an over-reliance on that system?
We're just not clear of when the doctor will be available at the hospital and when there will be telehealth. I mean, it's all part of this commercial in confidence nonsense that goes on. I mean, we need to know in our town what services are available and when they're available. And not to know is really stupid.
I mean, it almost sounds like your health is a gamble then as to when you're going to go in and get health. It could go either way.
Yep.
And people don't know when they present to the emergency department whether they're a triage 1, 2, 3, 4 or 5. You know, people, when they present to emergency, expect to see a doctor. I think that's it in a nutshell.
Yeah, definitely. I've just got some questions as well for Mr. Sandel and Mrs. Campbell. What are some of the problems that you identify as being associated with sending, just for the benefit of the committee, what are some of the problems that you see with sending serious dementia patients to Dubbo or other facilities further away. What does that mean for the patients and families on the ground?
Sorry, is that better?
Yes, that's great, thank you.
So, history in Warren is there has been a number of dementia patients, especially the early onset dementia patients that are physically very strong, very active, and quite terrifying for frail elderly people living in a facility to be cohabitating, in the same dining room, same lounge room area. And it has no locked unit at all, facility. So if they're a wanderer, they can't be kept locally and they have to be sent to a larger regional centre like Dubbo. So that means a family member that lives in the town of Warren has to drive 125 kilometres one way to be able to see their loved one. The town of Warren is actually in the very top corner of the Shire. The Shire runs for another 200 and something kilometres to the northwest. So, you could have a easy peasy 4 to 6 hour round trip to Dubbo to see your loved one. To sustain that,
Have people actually moved out of the area because they've found themselves in that situation?
No, they just do the miles. But it's really not sustainable because, they might only see their parent once a week or their mother or their, depending on the age of the person with dementia. But they're having to drive a lot of kilometres at a large expense. Some of them just can't afford to do it. It's quite a burden.
If I may,
Yes, please.
one thing I'd like to point out is usually when you get that older, confused resident that because of our facilities not designed for wandering or somebody aggravated, if they're moved on, their partner is usually a similar age. So usually you're asking a 70 to 80 or 80 plus year old to drive at least an hour and a half to Dubbo to see their lifetime partner. No good.
And is that, I can see how emotional you're getting. Is that really just tearing families apart? What if that other partner can't drive? Or
Absolutely.
doesn't have access to transport? Is that something you guys are hearing and seeing in the town?
Yeah, public transport's as good as non-existent in Warren. We have a community transport service Monday to Friday, but the volunteer drivers are very elderly themselves. Yeah.
And obviously transport in and of itself can't be the solution because there's so many other issues associated with that.
Yeah, and Warren is very much an ageing population. I think when we went from a hospital... Does that mean that
this problem's going to get worse?
It's going to get worse. And when we went from a hospital to a multi-purpose service, we did get above average beds and those bed numbers have increased over the years, but it's still not enough. We're still sending local residents out of town. Not just dementia, all sorts of residents, but yeah, dementia is our biggest problem.
The other problem that compounds it is the nursing and the professional staff and the care workers, because we've moved from a training program that was basically locally or even district or centrally motivated and worked for years. Because of shortages, the soft options being to call a contractor, get a fly-in, fly-out staff, and it is making a bad situation worse. We have to start training at a local level. We have to train up our staff. We have to give them some job opportunities and career paths. So if they take the job on at 16, 17 when they leave school, there's a career path for them. And this is what's happening. They're underpaid, they're overworked, and no career opportunity. We're going to continually go backwards. Absolutely.
Thank you.
Okay,
Thank you. I'm interested in just your views generally about multi-purpose services. I'll start maybe over with the Gulgong petitioners. Do you think they have been better for the community or not?
Speaking personally, I think, and actually not just personally, it was a common thread around town that services have gone backwards. in that we had a fully functioning hospital 10 years ago with a paediatric ward. We had a very primitive, but we did have a functioning X-ray facility. Not that there was minor surgery or maternity services at that stage, but in effect, the number of beds have been reduced, and it's quite common for an MPS only to be staffed by one registered nurse and one other nurse. And one of the problems with the telehealth was doctors would be giving a consultation and saying, right, take that patient for an MRI. And the nurse would say, there's no MRI. Right, send them for a CAT scan. There's no CAT scan. Send them for an X-ray. No, we don't have an X-ray. So I think perhaps the MPS model, and I understand that it's quite complicated when you were talking about the aged care funding, it's tripartite funded, but I'm not sure that it's actually fulfilling the function that it's meant to do in rural communities, especially as it seems difficult to put doctors in them, to attract them with that lack of support that a larger hospital or a larger facility might have.
Mrs. Campbell?
Can I say, Warren has had an MPS for over 20 years. Mr. Sandell was very active in securing a multipurpose service in the very early days of them being introduced. It did allow us to have aged care beds in Warren, and the community could see that it was required, and it functioned very well for a long time. I think the problem is that current local health district has actually lost sight of the fact that a multipurpose service was designed to suit each individual community's needs. So the size of the population in Golgong versus the size of the population in Warren or Nyngan or wherever else, that MPS was built to suit that community, staffed for that community, services for that community. But I think over the last 10 years, a one-size-glove-fits-all idea has crept in, and they're now trying to make all those multi-purposes exactly the same, with staffing, management, doctors, everything, and that's where it's failing. I think they have worked exceptionally well in the past, but they've lost sight of what an MPS is meant to achieve.
Because that's a very broad statement to say they've lost sight of what it was meant to achieve. So I just want to just delve into that a little bit. Has it, because I think from most of the submissions and evidence we've received, there does seem to be a less staffing as a result of MPSs. Is that correct? And I'll just note that Mrs. Pearson and Ms. Fellows are nodding their head. Would either of you like to comment?
Oh, definitely. We've lived in Golong for a long time, and of course you've seen a huge reduction in staff. A lot of the people who used to work there years ago, walking around town, you think, oh yes, when I was down there were 3 nurses and the children's ward, yes, heaps. Now they're calling on the cook in two of the written statements from people telling of their experiences at Golong MPS with the staff shortages. In 2 of those written submissions, they mentioned the cook being called in to help. So yes, definitely the cook didn't used to have to help in a medical capacity.
So I'll come back to that in a second. The population of Golgong over the last 10 years, what's happened to the population?
Oh, it's starting to burgeon.
So has it, okay, so you're saying it's starting to increase, Kitty. So so we didn't see 10 years ago, it wasn't like there was a sudden decline in the population to justify what has happened. So it's not a reason of population.
It's one of the fastest growing areas in the state.
Is it?
There's Central West, yes, Mudgee Golgong. Yes.
And just going back to the cook helping, could you expand on that? The cook helping how?
Well,
not with the food.
No, though she does do that as well.
I'm sure.
But I don't know. I know Mrs. Trevitt's daughter Hayley is going to speak to you later. She would have full details of that. But we're privy to a witness account who, on the night that Mrs. Trevitt passed away, she was in the next room waiting for her own emergency care, which didn't happen, and the cook came in to speak to her and perhaps form some sort of counselling role and let her know what was happening. And there was another occasion when Mrs. Barbara Size, who also sent a submission, when her husband was pronounced dead via the telehealth camera. Her family was not allowed into the room due to COVID restrictions, and the cook went and advocated on her behalf and said it was inhumane and could the family please go in. So the cook gets quite a mention in some of those Goldong submissions, and she's a very reliable person.
And clearly doing an incredible job in...
She's doing a great job.
Kate, might have to swing. That's...
Yeah, it's at the end of my time, yeah?
Oh, one more quick one if you like, and swing across. Government need their
No,
7 minutes.
that's fine. Yeah.
Okay, Government. Thank you, Paul, not right around.
Yeah. Thank you very much for coming in today and sharing your insights. It's really valuable for all of us to hear. I'll start over with the residents from Warren. I think firstly, congratulations to the Rotary Club for all the advocacy you've been doing, and it's great to read your submission. What do you think can be done now to actually progress the work around getting those spots for aged care and dementia? What is it we can do as a government that might actually help us, help you to do that?
Well, what we've done from Rotary being the lead role, we've started a Warren Health Action Committee, and that's specifically designed so all the communities involved, every section of healthcare, council, education, we're trying to bring them all in so we can move forward on training and upskilling, and because there is things out there, nobody knows about them. And there's a lot of things that need to be done. But one of the biggest issues I see, and I'm speaking personally here, because I chaired the first health council on the MPS when it started. 5 years later or 4 years later, I gave up. And I gave up for the reason that's been talked around here today. We've got to start communicating with local communities. Don't be frightened of their input, embrace it. I could 50% of the funding for Kalara House was raised locally.
I saw the $760,000, and that's amazing from the community to be able to...
That was just from Rotary, that $60,000 to transform a room in the MPS that wasn't properly used. That was raised by Rotary. Then we done the security fence, $8,000. Half the money for our sporting complex, which I know is not health, but this is the community you're talking about. Talk to them. Let them have some input. It is a win-win situation. We've got to do it.
Yeah. No, I can see the passion that you've got, and that's. I think it is. It's very much a community drive as well that you're doing. Ms. Campbell, have you got some insights as well?
Look, I honestly think the Department of Health has to come to Warren and sit down at the table with the Warren Health Action Committee and help us move forward. Working with the LHD is getting nowhere, so I think the Department of Health need to come to the table.
And for the Goldong residents, obviously we've spoken about the need to attract doctors, and through a number of the hearings that we've had, we found that throwing money at the problem isn't always the case. And in fact, almost to your point, it's about what a community can provide to the doctors as well. So do you have some insights into what you think we could do to attract more doctors to regional areas? Because we all know how wonderful our communities are. But we've just got to sell that to other people and, sell the community and also the role. Do you think it is just money, or do you think it is that there's other things that we can be doing?
Could I just, I have a son who went through medical school on a rural scholarship. He's a GP. He, at no stage, was required to work in the country, even though it cost the state an awful lot of money to I feel a bit disloyal here. But he got his degree and he's now working on the coast. Now he's 32. A doctor of that age doesn't feel supported in the country. It's not just about money. He said he feels guilty. Look, I should be coming back to Goulgong and helping you guys. But they're not skilled enough at that stage. They need mentors. And in the past, I think they joined a practice where there were other doctors to mentor them, and that's where he is now. So they've got a support team. So it's a lack of support from the medical aspect as well that is a problem. It's not about the money.
That almost sounds like a chicken and egg approach, though, because we haven't got the people there to support them. People don't want to come, and then, so when they come, then you've got more support for people to come. Is that sort of how you see it?
Well, I feel if they were bonded in some way, I know that's not a word that people like to hear. Teachers' bonds were done away with back in 1980 and everyone threw their hat in the air. But I think in some way, those going through on these rural scholarships, and they're quite common, are then allowed to work in areas that are not rural. Like, I don't think Coffs Harbour is a rural area.
Can I say, I've got a daughter doing third-year undergraduate medicine degree. She's one of 25 on the rural program with UNSW at Port Macquarie. She's the only child that comes from west of the coast.
Really?
But just to your point, with your son, now say he was bonded, how do we provide him the support to make it, like, if he was, coming back to you, how do we provide that support to him, do you think?
We need to do what Queensland does. They invest an awful lot of money into training rural generalists, and they've been very, very successful at it. And we have expertise. I think I missed it this morning, but you would have had Dr. Ian Iannuzzi here, and he's probably very modest, but he last year won an award for training rural GPs. So we have that expertise here. But we do have to look at systemic change with scholarships, with rural health scholarships, and we do have to look at financial incentives. We really do, because the current model is clearly not working. And we all come from very supportive communities and make our doctors welcome. Our doctor is part of our community, but let's face it, financial incentives, they're not the whole story. I know it's complex, but it's certainly going to be a big factor.
Yeah. He was very modest, but you could tell when he was doing his, like he was introducing himself, that he actually was very accomplished and had provided the community quite a lot of service.
Yes.
Whereas I think Natasha might have.
No.
Sorry, I know that we're running out of time. In your opening remarks, Ms. Fellows, you referred to some hate mail that you'd received. I'd just be interested...
I think that was Kathy, actually.
Sorry. I'm just interested to have a copy, if you're willing to give it to the committee. First of all, it's very serious if people are using official letterhead or if they're doctoring official letterhead and not actually from an organisation. So it'd be very good for the committee to have that, to then be able to refer that on to be looked at. So if we could get a copy and any of the other correspondence that you'd like to table as well.
I'm a little bit concerned about that, in that I felt these were nurses who were perhaps not terribly well educated. They were childlike letters, and I didn't take it any further at the time. Cheryl was away, and I just felt that, look, it was a bit sad they'd been groomed to write these letters, but I would actually prefer, I think, as a community, not to take that matter any further.
Okay.
Yeah, they all began the same way. All the letters sort of started off like almost a copy letter. I wear my uniform with pride, etc., etc. And Kathy, I was away, but Kathy wrote a very lovely letter in reply saying that, at all times we supported nurses' work, and it was actually their working conditions without the support of a doctor that we were really concerned for.
Okay. No, that's fine. I'm happy. I know that we've run out of time, so I'm happy to any future questions to put on notice.
And I just note, just to be very clear, that the use of official letterhead.
Yes, we knew that.
Yes, we knew that.
Goes without saying, yes.
Yes.
Okay, well, so thank you all very much. There may be some supplementary questions arising from the members reading Hansard and your very detailed and thorough responses. So what would normally happen is that the committee secretariat would liaise with you over those supplementary questions, and normally a 21-day turnaround time to return those to the committee secretary. So just before you leave, thank you very, very much. It's been most insightful. The submissions were good, but it's even better to have that opportunity to dig down and ask some questions. And
Thank you.
And I share the Honourable West Fang's comments, Mr Sandell and all the others, that extraordinarily work done by communities. I mean, communities aren't just standing there saying there's a problem, fix it to someone else. They're doing their very best to bring matters forward, but even themselves take it into their own hands and do very commendable things like raising money and what have you. So thank you all very much.
Thank you. Thank you.
Mrs Hayley Alvarez, Mr Christopher Pearson, Miss Rhonda Payne, and Mrs Sally Epringham. Thank you all very much. Right. Would you want to leave later this person or we don't know? Could be. Okay. Well, listen, we'll get underway. Thank you all very much for coming along this afternoon. And particularly you, Mrs Alvarez, with your most difficult circumstances. And there's a strong sense of condolence from all members in regard to the death of your beloved mother, Dawn. So we want to communicate that to you before we start. So we'll get through the formalities if we could, which is the swearing or affirming you in. So starting from my left with Mrs Alvarez, get you to state your name, your position title, but that is a private citizen, I think, for all of you, and then take either the oath or the affirmation, whichever you prefer, and the words of both should be before you. So we'll start with you.
Certainly. Hayley Olivares, in a private capacity.
Thank you.
I'll take an affirmation, thank you.
Thank you, yes.
I solemnly, sincerely and truly declare and affirm that the evidence now and about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you very much, Mrs Olivares. Mr Pearson.
Yes, Chris Pearson, community member of Gulgong. With an affirmation, I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you very much. Ms Payne.
Rhonda Payne from Wellington, private citizen. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you very much.
Sally Epringham, private citizen. I swear that the evidence now about to be given by me should be the truth, the whole truth and nothing but the truth, so help me God.
Thank you very much. So can I just, first of all, once again, thank you all for coming along. Your submissions have been made, of course, to the inquiry, have been received and duly processed, and stand, Mr Olivares, as submission number 575 to the inquiry. Mr Pearson, as you would know, it's number 214 to the inquiry. Ms Payne, your submission is submission 583 to the inquiry. So that's the formal number it's gave when it's received, and it's listed on the inquiry's webpage. And Mrs Epringham, yours is submission number 199. So they've all been received, processed and uploaded onto the inquiry's webpage. You can take them as read by the committee members. So in your opening statements, which I'll invite you to do so shortly, there's no need to read from them, but rather perhaps draw some of the salient points out and set the scene, because what we'd like to do once we've completed the opening statements is to, if you're agreeable, opening it up to some questioning. No doubt we're going to be covering some difficult issues in the discussion in the next 45 minutes or so. So at any stage, if you just need to have a pause, feel free to pause, have a water, just you know, as best you can, just take it at a pace. We're not going to rush or push, we'll just work our way through it, and I'm sure we'll cover everything satisfactorily. So with that said, I presume, can I that all of you have an opening statement of some sort to make. Does everyone have an opening statement?
If I may, Mr Donnelly, could you bring your microphone a little closer,
I
please?
certainly can.
Thank
People
you.
don't normally complain about that, Mr Pearson, but I'm happy to...
Industrial deafness is with us.
No, okay, fair enough, no problem, no problem. So
Thank you.
Is that better? Better, hopefully. So, we'll start with Ms Oliveri. So thank you so much once again for coming along, and we acknowledge the circumstances that are before us. Yeah.
Thanks. Good afternoon, Chair and committee members. I thank you for the opportunity to be here today. I sit before you as a daughter whose mother fell victim to an inadequate and ill-equipped medical system. My parents moved to Golgong in 1989. I completed my schooling there, and my mother contributed over 20 years of her teaching career at those same schools. She was a beacon of hope for many struggling students and families over those years. Her loss continues to be felt deeply by our family and across the Golgong community. On the 15th of September 2020, my mother was unwell, there's no question about that. She was picked up by ambulance and taken to the Golgong Multi-Purpose Service, a facility that had been without a doctor for months. New South Wales ambulance protocols at that time mandated that she must be taken to the nearest medical facility, with paramedics knowing there was no doctor servicing that facility at the time. She was triaged Category 1 on arrival by a registered nurse, and according to New South Wales Health, should have been seen by a doctor within 2 minutes. Instead, it took 35 minutes for any communication to be established with a doctor via telehealth, during which time my mother's condition significantly deteriorated, and within an hour after initial contact, she was dead. The government directed what our family was led to believe would be an independent review into the events of that afternoon. Perhaps that's what they wanted us to believe they would do. What was done was a root cause analysis, completed by a panel of internal New South Wales Ministry of Health staff with no independence whatsoever. It was a conflict of interest, and the report reads as such. In fact, the liaison officer our family was appointed for the duration of the review identified she indeed knew my mother from a previous presentation at Orange Hospital some many years ago when she had a shoulder replacement. The liaison officer had no problem in passing comment to me on my mother's personality and her aversions. This was my first red flag that this review was problematic and possibly full of bias. The report did identify inventory shortfalls, including needles and headsets. It confirmed staff concerns around resuscitation efforts my mother received due to the fact there was only one working headset that could connect to the telehealth system as opposed to two, which in turn confused staff around the rate of compressions during resuscitation. It identified limited knowledge around scope of practice between MPS staff and paramedics. Yet the report concludes, and I quote, "This did not affect the patient's final outcome in each of the areas identified above." My mother died alone, with no family present. She would have been terrified. We were not afforded the opportunity to see her, with an individual outside of our family identifying her deceased body. It was 13 days later that I got to say goodbye to her at a viewing at the funeral home. We had no contact from any doctor or medical practitioner from Western LHD. I had no idea what happened to my mother on that afternoon of 15 September until I read the root cause analysis report provided to me in January 2021. Despite strong requests, our family was denied a post-mortem examination. The original cause of death, as communicated to our family by a police officer the day after my mother's passing, was later contradicted on a coroner's certificate. In my opinion, there are numerous non-evidentiary conclusions drawn in relation to my mother's cause of death. No pathology was taken and no doctor physically saw her before or after her death. There have been numerous comments by senior health department employees and government representatives that a doctor at the Golgong MPS that afternoon would, and I quote, "not have made a difference in this lady's case." I'm not as convinced, nor do I accept that that makes what happened that afternoon, or to the hundreds, if not thousands, of other individuals who have experienced inadequate healthcare across New South Wales acceptable. When did we get to the point that the level of healthcare you should expect to receive not only depends on your postcode, but also on your likelihood of survival? At what point did it become acceptable to have a multi-purpose service open for business with an emergency and ambulance sign out the front and no doctor inside the walls? It's false advertising. It fills the community with false hope that they will receive appropriate care should they need it, when in fact we could not be further from the truth. The system is failing. It failed my mother, our family, their community, and it will continue to fail unless acknowledgement turns into accountability. There must be change. There must be system reform, appropriate allocation of resources, and cultural change in the leadership, where instead of deflecting and defending, they commit to redress. People are dying. Families are broken. We can't continue to ignore this issue. Thank you.
Well, thank you very much for a very clear and strong but measured statement. We can't imagine how you feel in the circumstances, but you didn't allow your emotion to take you away. You were very frank and clear. And once again, on behalf of the committee, we offer our condolence for the terrible loss of your mother. So we'll move to the other witnesses and we'll open up for questions. So, Mr. Pearson.
Thank you, Mr. Chairman. Well, good afternoon and thank you for the opportunity to address you. I will be brief. I have supplied you with a little fact sheet, facts numbers 1 to 9, which I may refer to, but I hope you find those useful.
Mr. Pearson, would you be good enough to actually ask to table or ask us to receive that fact sheet?
I'm sorry.
So that's just so we can duly process it as a document to this inquiry.
Okay, thank you. I will.
We're talking about the same document, are we?
Yes.
Yep. Okay, so.
Yes, my opening statement.
Thank you very much. So you're tabling that as your opening statement, thank you.
Thank you.
And just so we're clear, it's a document which is headed opening statement, underlined inquiry into health outcomes and access to health and hospital service in New South Wales. Got your name, and over the page goes on, and that's the end of that. And then there is a third page which is attached with some highlighted names of jurisdictions.
Yes.
Okay, thank you. Please proceed.
Thank you. So I speak as a resident, a private citizen of Gulgong, having lived there for some 37 years. And Gulgong District Hospital, and I think that term district is a very important word, it once proudly served a large hinterland. We had 28 beds, men's, women's and children's, an operating theatre, a maternity section, a maternity ward, x-ray facilities and a helipad which was built by the community. Services provided in this grand building, not unlike this one where we are today, were reduced to the point of closure in 2010 following demolition of the premises in 2015, leaving us without a dedicated facility. Unfortunately, the new MPS is inadequate in size and the services provided. In the early days, I, like many parents in Gulgong, were pleased and felt safe in the fact that there was 24-hour care available for children and anyone else in the area. It beggars belief that the above-mentioned services have been reduced in spite of the population growing at the rate it is, and I refer you to the statistics at the back. Point number 4, point number 3, point number 2, point number 1. So forced amalgamations within the health system, stripping of equipment and assets, often funded by the community, faceless administrators without local knowledge or an interest in the community, all highlight a need for a new business model for remote, rural and regional health service delivery in New South Wales. Not a day goes by without some preventable horror story coming to light. I realise that not every regional town can have a base hospital, but I do, however, feel that any existing health facility in every regional town or city should provide 24-hour care to the community by qualified staff, certainly by a GP in the form of a GP or as a VMO. Surely this is a basic right in the first world country. To phone Gulgong's MPS after hours and be told, don't come down here, go to Mudgee, is not acceptable. There's scant regard for the condition of the patient, how you are going to get to Mudgee, etc., etc. It is just a fob off. I've mentioned in my opening statement the model of healthcare, and I refer to that lovely gentleman from Warren who referred to the government embracing the community. And again, I urge you to look at recommending or considering the reintroduction of the old hospital board system, perhaps in a new guise, because the existing system of health councils is a toothless tiger on a very short leash, whereas the old hospital board system in Gulgong was made up of 10 people. They had the ability to hire and fire. They oversaw the duties of a CEO and a matron, and it provided a conduit for the community to take their concerns directly to the health department via these very capable professional volunteers whom I dare say saved the government a lot of money in the long run due to the hours spent on the job providing a much, much better level of service than there is now. So to that end, I thank you for your time and welcome questions.
Thank you, Mr. Pearson. That's a very helpful opening statement, which obviously you've provided in writing, and we much appreciate it, and we particularly find it helpful to have those specific references notated in the opening statement as well. Ms. Payne.
Late in 2019, through the night, I thought I was having a heart attack, and of course stupidly waited until 6 o'clock to go to the hospital, but that's what one does. So I went to the hospital. Fortunately, there was a doctor on board at that point in time. And,
sorry, just to be clear, this is the Wellington Hospital?
This is the Wellington Hospital, and so they took the blood test, went away, came back, and he said, definitely no heart attack, no worries. He said, but I found something else in your blood test that needs to be dealt with. Didn't tell me much more at that point, asked me who my GP was, and said that he would have all the information for them there and that I needed to make an appointment fairly soon. As it turned out, I have it's like a reverse blood cancer where I make too many red blood cells. If it hadn't been found at that time, who knows when it might have been found, but I was lucky. There was a doctor on duty. If there'd been a nurse there, I probably would have just had the heart attack, nothing happened, and go home. So that, for starters, is we need doctors and we need them there all the time. Swap to present day. Last week I had a scan in Dubbo, and they told me that it would be, that was on Tuesday, they told me it would be delivered to the practice, to my doctor, on Tuesday afternoon.
Your doctor being located where?
Here in Wellington.
Thank you.
So it would be there. So that was fine. I rang when I got home to make an appointment to see the doctor about it. Unfortunately, that was last Tuesday. We're Tuesday again, and the first available appointment with the doctor was next Tuesday. So we just live hoping that it's not too bad. But that's the way medicine is at the moment for us here, because we have so few doctors that making an appointment, whereas once you could get one very quickly, it no longer is. Having trained, and people talked about it before, having trained as a teacher where I was given a scholarship and then I had to go and do my country duty before I was allowed to choose where I go, I really have trouble understanding why we can't put some money into training doctors or assisting them with their training to have some years of practice, the same sort of thing going on, to get us some. I'd rather have a young doctor that really doesn't know quite as much as the old doctor than have no doctor at all. That it's unfair to the nursing staff and everyone else. So I think encouraging that. And is it time to change what I called in the registration process, but someone suggested that it was a Medibank number or something that doctors get when they're graduated, when they're ready to start work, and have some of those numbers attached to health areas so that, you know, at some point you have to go to a health area that may not be quite as good as the one at Balcombe Hills or, you know, Manly or wherever you would like to be, so that we can get more doctors here to take the pressure off the people that are already working here. Knowing that Dr. Spencer is working long after I certainly gave up my career. So it's a difficult situation, but something needs to be done. So thank you very much.
No, well, thank you for those
my opening statement.
No, thank you. And what you've elucidated is what we've heard from other hearings, and some of the ideas you put forward are also similar to what we've heard elsewhere, but they're very valuable contributions. Ms. Nemrican.
So just to put it into context, I live at Nevertar, which is a blink and you'll miss it town, about sort of midway between Nyngan and Warren. So those are the hospitals that we frequently, when we need to, we use. So that just gives you a bit of context. So we're an hour and a half from Dubbo, and a property that my husband manages is another half an hour from Nyngan, so effectively 2.5 hours from Dubbo. So our experience of those MPS local hospitals is that they're having more and more services cut, that they're often without doctors, or if there is a doctor, it's a GP who's worked all day who's also the VMO, which has its own issues attached to that in terms of overwork. A lot of the doctors are foreign trained. In essence, there's nothing wrong with that, but the reliance in rural Australia on foreign trained doctors and locums is creating a whole other set of issues in terms of lack of continuity of care. There's no attachment to the community. There's no context known around what the community needs and the issues that community faces. And there also is, unfortunately, often a communication issue as well. My feeling is that these MPSs are being stripped of services. The nurses are fantastic, the services are new and modern, but they don't have doctors and they're not providing facilities. And they're essentially becoming nursing homes and palliative care units for the most part. Just some little examples. I was pregnant and working in Nyngan, and I had to pick up my daughter from daycare and drive 2 hours to Dubbo on my own to have a complication checked with my pregnancy, because there's no prenatal services, there's no maternity services, and there's no child services any longer in those hospitals. One of my daughters broke her arm not long ago during harvest, and it was a 3-hour round trip to Dubbo to have her arm x-rayed. We have an x-ray unit in Warren, and we were told not to go 5 minutes up the road but to go to Dubbo. There was no explanation given other than that's just what we had to do. When it came to be reviewed, that was exactly the same situation, 3-hour round trip. I had one of my daughters probably about a year or two ago. She just had run-of-the-mill gastro, but we presented to Warren Hospital and were told that they couldn't hold her for more than 6 hours. We had to go to Dubbo. Again, no real explanation given other than that they no longer cared for children in the facility. Another accident, we've got jackaroos and young children, so things happen quite often. I had a child who fell off a horse, and they did actually have a helicopter waiting to go in Orange, but we were taken into Warren and told that we had to be transported to Dubbo for observation. Again, that was fine, but when we were in the ambulance going to Dubbo, they let slip that actually meant that Warren had no ambulance service. So in an emergency, there was nothing left in town, and the guilt that I felt about that is just absolutely appalling. That a whole town would be left without an ambulance because my child can't be seen in Warren and has to go to Dubbo. So I also think that then becomes an issue for Dubbo, because these local hospitals are no longer able to facilitate and look after their community. Everything goes to Dubbo. So, you know, it's a month-long wait for a GP appointment. It's 6 months to see a specialist. I'm also a teacher, and I've got kids in my class that are waiting 6 months, and that's 6 months of their school career that they've lost because they can't hear, or they've got recurrent tonsillitis, or, you know, there's some behaviour problem that if you're in Sydney, you would see a paediatrician, I'm pretty sure. Like, I'm not there, but I can't imagine that, you know, this is an acceptable situation for these kids. And, you know, that's a 24th of their schooling that they've lost due to, the inability to see a doctor. And, I also think it then becomes an issue of there's like a 3-tier system of medical access. There's those that can go to Sydney, like my family, we go to Sydney to see an endocrinologist because when we started seeing one, there wasn't one in Dubbo, and we've continued that relationship, but that's a 1,200 kilometre round trip. Then there's the people who can only afford to go to Dubbo and wait that 6 months and see whoever's there. And then there's the people who can only afford to go to Warren and see whoever or no one. So, there's that socioeconomic cost as well. And it's in terms of travel, it's in terms of access, it's in terms of education and knowing how to access those services as well. And I think that there's the flow-on effect mental health-wise as well to these patients in these rural areas, to the nurses that are trying so hard, to the families. And I do feel that, the hospitals are understaffed, they're under-resourced, and as a result, patient health and wellbeing over the long term is compromised. And I know, in the teaching profession, up until not that long ago, there was a point system, there was incentives to go to rural areas, there was extra funding. I think if you value something, you put money towards it. And I know the government's probably going to say, well, we can't afford it. Well, you can't not afford it. Like, all your food, your fibre, all your exports are being created, west of the Great Dividing Range, and, we're struggling to access healthcare. And I mean, honestly, my husband says, unless it's a spinal injury, you get in the car and you go to Dubbo, because that's just the reality, and that's an hour and a half away. And I'm sure, the economic cost of those type 2 diabetics that aren't getting early treatment, those kids that aren't getting medical intervention when they need to, and their education's suffering and their work prospects are suffering. Whatever money is being taken out of these local hospitals is being lost in the economic fallout of what's happening in these rural communities.
Thank you so much, Mrs. Epperingham, and thank you all for coming today and sharing these stories. It's really important to hear from you all, so thank you. We're now going to split up. I know there's going to be a lot of questions for this group, but we're going to stick to the 7 minutes, and I will start with the Honourable Watsecord.
Thanks, Ms. Hurst. Thank you all for your evidence. And Mrs. Oliveira, thank you for your evidence. And I know it's very, very hard, and you've been very, very strong today. How did you and your family find the strength to stand up to the local health district and find out what happened to your mother?
I live in the city, so I live in Canberra. So first of all, I guess for me, when I found out the day after Mum had passed that there was no doctor at the hospital, I was appalled. So I am comfortable in Canberra. We have a great medical system, and I guess I didn't realise how much we took for granted. It's not hard to find strength when you find people that don't have the same access to critical services that you do. The Goulburn community has given so much to me and my family over the years, and for me, when I found out after Mum's passing that the community had been advocating for this issue in the months prior to my mum's passing, I felt an obligation, I guess, that now they had a voice and a poster child, I guess, which is a disappointing way to put it. But my mum then became the face of what the catastrophic result of this problem can be. And until they had that, nobody was really listening to them. So I wouldn't say that it necessarily was strength, it was circumstance. And the fact that the community have already been trying to get this issue addressed well before my mum had passed.
Now, I understand that the local health district has apologised to you and your family, is that correct?
Not directly. So I've had, outside of the root cause analysis, I had no contact from the Western LHD. Publicly, absolutely. We received lots of condolences in the public forum. So, I got to the point, I guess, where I said, when I spoke to any of them, I said, I don't want to hear your condolences anymore. I just want to hear what you're doing to fix the problem. So
Now, the feedback from the community, has Gulgong Hospital improved since the passing of your mother?
I don't know because I don't live there.
Okay. Would you mind if I ask the other members? Sure. Mr. Pearson?
Yes, can I have the question again, please?
Since the passing of Mrs. Olivier's mother, has Gulgong Hospital improved?
To the extent that we have a VMO, albeit with limited hours, as pointed out by the previous group of speakers, yes, I'd say there is a slight improvement, but only in that area, in as much as we do have part-time doctor on board.
Now, we heard evidence earlier today. Several people have referred to a cook at the hospital providing assistance. Do you know anything about that?
I was not there on the evening, but the statements by those corroborated by quite a few there on the evening certainly point to that, and I would not disbelieve it at all, knowing the people as I do.
Ms. Olivier, is there anything you'd like to add or observe about that?
Yes, so I received a statement from the lady who was in the adjoining room to my mother in the MPS the afternoon of Mum's passing. And I've got her statement if you would like to hear the reference to the cook. So this is from her account, obviously, of her attendance at the MPS. We arrived at the MPS at around 4:30 p.m. The nurse on duty took me into the room and was getting my details. While she was doing this, an ambulance turned up with another patient. This patient was put in the ward adjoining the room where myself and my husband were. Understandably, she had to leave me to attend to this patient who appeared to be very unwell. My husband and I could hear everything that was being said. As Gulgong MPS does not have a VMO, the nurse was relying on a doctor through telehealth. There were only 2 nurses on duty at the time, as I heard someone ask if there was anyone else there and they were told no. That person then asked who's going to look after the other patients in the MPS at that time, and the answer was the cook. I believe that there were 2 paramedics present as well. I heard the paramedics say that they had been unable to get a cannula into the patient before bringing her into the MPS. I don't believe the nurse was able to get one in either. And then I heard the nurse saying that she was trying to get an IO in. It was at this stage that I heard the nurse basically pleading for assistance from the paramedics, but they said they were unable to do what she required.
Sounds like the cook helped out. Thank you.
You've got 2 minutes
Oh.
if you want one more question.
No, I'm playing at
You're
the
right.
stage.
Okay.
I'm playing at the stage.
I just might jump in and throw it. Just got a few questions for Mrs. Empringham. Sorry. You mentioned in your submission about that there's an X-ray machine in the hospital, but nobody that can use it. And you had to travel one of your children. How long?
So it's a 3-hour round trip.
And was your child in pain?
Yeah, she was. Yeah, my husband rang Warren and was told if he was concerned about her arm to go to Dubbo. Yeah, and there's an X-ray machine in Warren.
And I understand it from your submission that you've actually made a very personal decision not to have more children because of, and is that because of the lack of healthcare?
Yeah, that's exactly right. I have 2 friends who've delivered children on the side of the road, and myself, I've had complications with pregnancy and had to drive myself 2 hours to Dubbo to be checked out. There's no prenatal care, there's no maternity care. There's basically nothing in an emergency. I mean, I've had one of our neighbours lacerated his forehead and he went to Nyngan, was told there was no doctor. They rang Warren, they were told they had a doctor but no suture kit, so he had to drive the half an hour to Nyngan and then he had to drive an hour to Warren carrying his own suture kit. That's the level of care that, you know, is provided.
Sorry, Ms. Hurst. Was the no suture kit, was that at the hospital or?
Yeah, that was at Warren.
No suture kit at Warren Hospital?
Yeah.
So what do they do at the hospital?
I have no idea. I mean, look, and as I said in my opening statement, the nurses are fantastic. I know them personally. You know, they're wonderful people, but they're operating, you know, it's basically a medical centre with a palliative care unit and an aged care unit. That's what it appears to me as someone who's part of the community.
How long ago was that, the suture kit?
The suture kit was probably 2 years ago. Yeah. I mean, my youngest child is now 11, so I'm talking about my, you know, experience, but in saying that, you know, the broken arm was harvest last year, so that's November. So, you know, it speaks to, there hasn't been a huge amount of change from what I can tell, you know, in that amount of time that you can't assess a broken arm and x-ray it in a hospital.
Wow. You know, obviously you love your community and you're a real part of that community. But if someone was coming with a young family and asked if you would recommend that they come and move into the area, what would you say to them?
In terms of if they had prior and existing health conditions, I'd say don't. And I still feel that our health is a gamble where we live. It really is. And that's one of the reasons why we don't have any more children. It was not something that I was prepared to do. I mean, I do live in fear that something happens. We've had jackaroos fall off motorbikes and had lacerated livers and, you know, also like a whole range of things, having young people and horses and motorbikes about. And it is a gamble whether you're going to get care in... And it's not care as in, you know, obviously they all care and they do their best, but care that actually prevents you from passing away is a gamble. And you know that, you know, a decent amount of emergency medicine care is an hour and a half away. Probably 10 years ago, another one of our neighbours, she had a thumb ripped off by a horse, a lead rope got caught around it. They got her to Warren, she was flown to Dubbo. It was 8 hours before she was even got to Sydney. Now, they could have driven, you know, there in 6 hours. Like, it's that sort of, you know, medical delay that, you know, and it's time and time again, it's story after story. It's not, you know, an isolated incident.
Thank you. Ms Fannin?
Thank you, Deputy Chair. So this committee, this inquiry has heard pretty much from most members of the community and stakeholders about what seems to be cuts to health services in regional, rural and remote New South Wales over the past 10 years, say. Do you agree with that statement? And I just wanted to, do you agree that's your experience as well in Golgong, Mr Pearson?
Yes, most certainly, yes.
Ms Payne?
Yes.
Mrs Effingham?
Yeah.
When you look at what Golgong had some 10 years ago, I mean, 28 beds, a matron, a CEO, all on site. It's terrific. And yet we face this very rapid population rise, stymied by the postcode system, which you may find interesting, and yet our services are being reduced.
So it's not like there's this comparative reduction in population to justify a government decision to reduce healthcare services?
Definitely not, no.
And I think, you know, the other issue is it's all being centralised. And as someone else said, I can't remember who it is, we don't expect a base hospital in every town, but there has to be a level of care, especially emergency care and, you know, prenatal care. It's a timely thing. You've got patients who are coming from Bourke to Dubbo. You know, Dubbo's the cut-off line for any sort of care west of the state. Like, that's a huge area that they're servicing. And no matter how big or efficient your base hospital is, you can't do that well over that distance.
And is it a false economy where you have to have 2 ambulance officers off duty, so being paid penalty rates, driving a patient a long distance to get to a base hospital? Are the costs, incremental costs to reach that point, less than having the facility available in the hometown? I don't know. I'm not an economist or a government official, but it rather looks like it may need revisiting. Centralisation is a great thing, but only if it works.
Mrs Olivares, your mother passed away in a multi-purpose service centre, which was a hospital, which at one point would have had a doctor available. Is that correct?
That's correct, yes.
Not
only that, but there was a doctor in town who had the previous contract to service that MPS. So at some point, the government made a decision that whatever financial differences there were between what the doctor wanted and what the government were willing to give him were not viable enough for those months to reach an agreement to reinstate that doctor. So my mother died in a multi-purpose service with a doctor in the town who the government would not contract to support that service.
How do you all feel when you hear that, for example, this government, say, has spent $14 billion on a Western Harbour tunnel in Sydney, which is part of a $70-something billion transport spend, or $1 billion on an ANZ stadium rebuild? What do you think in terms of what priorities this government is giving regional health compared to other priorities? Mrs. Olivares.
It's disproportionate. So I feel like regional and rural New South Wales are forgotten.
Mr. Pearson?
Yes, look, I agree with Hayley on this. It's well and good to have new infrastructure. It may be good for the city, I don't know. But we're not talking about new infrastructure in the country, we're talking about existing infrastructure that needs maintaining and upgrading according to the population growths and the needs of the community.
Ms. Payne?
Having lived in Sydney for quite a while, I sort of think that the government would be much better off trying to find a way to have people using less cars in the city. So building extra tunnels and things is only going to put more people on the roads and make travelling in Sydney just really appalling, whereas at the moment it's just appalling. But that's personal, and I've lived in Wellington now for sort of 20 years or something, but I think that we need people's health more than we need extra car travel, and buses and trains would be much better for the whole world.
And
I will
finally,
have to
Mrs.
cut it
Everingham,
off there and move over to the government questions because it's gone quite a bit over time. Does the government have any questions?
No, you go.
Thank you, and thank you very much for all appearing today and sharing your stories. I guess just leading on from the political point that Ms. Fairman was trying to make, which I don't think is really fair.
I thought it was pretty good.
We know that even if we spend, double, triple the money, it's attracting people to our areas, which is actually the issue. How do you think we can actually do that better? Because Ms. Payne, I read your submission.
And
talking about getting people to come to here to Wellington. And
I sort of think that I started my teaching career in the country because that was where I was sent because I was on a scholarship and I had to go wherever they said. So, that was the way it was. And, I did some country service, did some city, and I came back to the country. But it's one way to get people to come. If we pay for part or all of their education and say, if we do this for you, you have to then either pay all the money back or you go to the spot where we say we need help, we need doctors, we need whatever, and go that way. And to be honest, if I've got a beginner doctor looking after me and we're going to, use the screen to talk to another doctor, I'd rather have a trained doctor than the trained nurse. So, the doctor themselves could get help from other specialists, other people around. And it takes the pressure off the nursing staff.
And if you don't mind me asking, when you were a teacher and you were, asked to come to, say, a rural regional
Forget
area.
asked.
Sorry?
I was told. I was just given the.
I was trying to be.
No, we just went wherever.
When you were told where to go, were you provided support by other teachers or by the department?
I went to a high school. I went to Narrabri for that, and I just appeared as every first year art teacher. Fortunately, there was another music teacher in the school, so I wasn't alone as such there because it was a bigger school.
Because we heard earlier that I guess some of the concerns would be around putting a junior doctor in a town where they wouldn't be supported.
But most schools have senior teachers as well as junior teachers, so there was never a problem with that.
Yeah.
But
how do you think you would address having, say, just a junior doctor?
In a town Wellington size, if you've got a junior doctor, there are 2 clinics, and one would assume that there would be some more experienced doctors in those 2 areas where they could get help. And wouldn't it be then easier for a doctor to get the help from another doctor through the tele-system than it is for the patient or for the nurse?
Yeah.
So at least the doctors would be talking the same sort of language, whereas, the nurses, it's slightly different.
I know, and it's valuable to get this input because, we are trialling different things like, doing rural medical schools where people will do all their medical training, in a rural regional setting.
But that doesn't mean they'll work in the country.
No, but we're hoping that they will. I mean, I grew up in Wagga and I moved back to Wagga after I had a career and, we're hoping that these people will train there. But it's also, how do we get them to come to other places like Wellington or Golgong and actually embrace that community?
Well, there's a part of me that says, if we've just paid for it all, this is where you go. I don't think you have to necessarily, like if I've just got a free education, and as a doctor it's, going to be a lot of money, why shouldn't they be able to say, well, we paid for that, this is where you go, and you spend, 2 or 3 years there, get some experience. I sort of think that we're being so, we don't have to be that kind to them. We've been kind enough to pay them.
No, but sorry, can I just say something? Sorry, Rhonda, I went through I was a teacher trained 17 years ago, so we're not talking about a terribly long time. I was a targeted grad, I went to Coonamble, and I fell in love with the town. I think unless you go, you don't know, and quite often people do stay. It's the incentive to go there in the first place, and I mean, I completely agree with Rhonda. If you're getting something for free, you don't have to take anyone up on that, but there needs to be something given back to these towns. And, there should be scholarships. There should be incentives on offer. I liken it to mining. No one would choose to live in half the places that there are mines, but they pay enough money that people go there. So, this whole idea that we can't get them there, money talks, I'm sorry. If you pay people enough, they will go. So, and I mean, I'm quite prepared to be proven wrong, but, incentive schemes and paying people money, I am convinced will get them there. If the mining industry is anything to go by.
And how much does it cost to become a doctor? It must cost a fortune. So if the state pays a fortune, I think the state's entitled to say, this is where you can go.
It's a very, it's a multifaceted problem, and I don't know that there is one solution, but it's getting this input that's really, I think, valuable for us. So,
and there'd be lots of poor smart people that would happily have it. It's all right if you've got a wealthy family and they can pay for your education, but
it needs to be seen as an investment.
Yes.
Because even in Golgong, as progressive as the town is, when the elderly retire, they think we need to go to Mudgee or Dubbo or someone where there's a hospital and where there are doctors readily available. Now, if that were done in these other smaller centres, the flow-on effect, I think, would be immediate because the schools would improve, the doctors bring families with them, people are encouraged to move to the town because there is this basic right of a medical service available 24 hours a day. So I don't think it's rocket science. I think it's purely an economic matter which needs to be addressed.
And I think it starts at the university too, put aside X amount of places that those people, have committed to working in rural areas, Fund the doctors to support those people. That's what happens in education. I don't see that it's any different.
Thank you so much, all of you, for coming here today and giving your evidence and giving your stories. I know some of those stories were very hard to share, so we really do appreciate people and you guys coming forward. I don't think there was any questions taken on notice. So again, thank you for coming today, and we'll prepare for the next witnesses.
Thank you.
Thank you. Could each witness, starting from my left, please state their name and position title and swear either an oath or an affirmation.
Joan Staggs from Gilgandra, and you would like my oath, is that correct? I swear that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth, so help me God.
Thank you. Mrs Richards?
Carol Richard, I'm from Coolah. I swear that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth, so help me God.
Thank you.
Diane Simmons from Mudgee, private citizen. I swear that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth, so help me God.
Thank you. And do you all have a short opening statement that you'd like to read? I'll start with Mrs Staggs.
Mine is the same as in my submission. The purpose of this communication is to express my concern about the Gilgandra multipurpose facility. Originally in 2019, I passed on these concerns to the hospital board and to the local member of parliament. At the time, I had a friend who was chronically ill, so I was visiting on a daily basis. Sadly, things have not improved in all that time. So no criticism of the staff at the Gilgandra Multipurpose Centre at all, but the points are in my submission and I will talk to you later. Thank you.
Thank you. Mrs Richard?
Yes, and I have some papers that I'd asked to be tabled.
Yes, fantastic, thank you.
So I've just summarised the points in the other.
Perfect, no, thank you very much for supplying this. Okay, great. You may start, thank you.
Thank you. Now, there have been other inquiries in the past. New South Wales in 97, a Senate inquiry in 2007. The issues for country people remained constant and serious. In 2007, the AMA concluded that limited access to health services is a significant issue for people living in rural and remote Australia. An inadequate supply of hospital and other health services and workforce shortages in these areas were identified as key factors. And this is exactly the same case in 2021. From January to March 21, Coolah had no resident doctor, nor was there a doctor at Dunedoo. A doctor was appointed to Coolah and commenced in March. He has limitations on S8 drugs and is not able to do mental health plans. This is of high priority in this district, with major disastrous bushfire 2017, followed by drought, severe storm events, current horrific mouse plague, High Court case over eviction orders for 17 resident owners at Coolah Home Base Park, and now proposed land resumptions with high voltage transmission lines over prime agricultural land. Though many Coolah residents with chronic and ongoing medical conditions have found new doctors in Mudgee particularly, there is still high demand in Coolah for GP services. Regrettably, there have been a number of incidences of dissatisfaction with the service provided, in particular relating to mental health issues, waiting times and inability to obtain referrals. Coolah was promised 2 more doctors, one in supervisory capacity to oversee the practice of Brenshaw Medical at Coolah. Bush Telegraph says that this is delayed through issuing Medicare provider numbers. These other points are older points. In March 2018, the Coolah Hostel Community Committee was formed to negotiate the return of the aged care hostel to the community for the original $1 transfer fee. Western New South Wales Local Health District has apparently forgotten the issue, while the lovely building sits empty and deteriorating. Telehealth has limited appeal to many older people, particularly in regard to mental health problems. There may be a breakdown in understanding the constraints of rural districts where a telehealth doctor authorises an overnight ambulance transfer for a locally assessed non-urgent case, leaving communities without paramedic support. Paramedics in Coolah have identified one serious discrepancy that occurs in rural towns. Specifically in Coolah, we have defibrillators at sporting venues, but none in the main street, accessible 24/7. Improved equity in health requires greater investment in those factors outside the formal health system, not just increased access to illness-oriented services. In Coolah, we have several local highly trained nurse professionals who struggle to find work-friendly environment under the high pressure of poor support services and overload that forces their resignation in favour of their own health and relationship outcomes. We have become reliant on contract nurses and nursing assistants who do a remarkable job under very trying conditions. As recently as 2 weeks ago, a person under the effect of drugs hammered on the doors of the MPS at night for admittance. Police were phoned but said they would come in the morning. A critical incident report was filed. Under the worst case scenario, the person could have gained access by force. In addition to the high workload of nursing staff, the domestic staff are also under the pump. The MPS has a huge floor area with many sitting rooms and individual bathrooms and GP consulting rooms. One staff member has requested an 18-hour fortnight, and with additional call-ins ended with 83 hours in a month. Unsustainable for her with a family and farm to consider. These assistant staff members provide a huge backup to assistant nurses in patient care and welfare, bringing a pleasant social presence to the oldies.
Thank you so much, Mrs. Richards. Mrs. Simmons?
Diane Simmons from Mudgee. My husband and I have been constant receivers of local doctors and nurses' kindness and expertise over the last few years, and we have witnessed firsthand the medical staff run off their feet, struggling to cope. It is very distressing to witness. I came to Mudgee 41 years ago. In the early years, I had the following operations in Mudgee: gallstones, the old-fashioned big zip method, nose operation, hysterectomy, etc. Now, gallstones, for instance, is a much simpler keyhole operation, but it can't be done in our local hospitals. You have to go to Dubbo. Why? About 1999, I started working at the Mudgee Guardian newspaper as a journalist. One constant story was our deteriorating health system. We were losing doctors and hospital facilities. Operations in Mudgee were disappearing to city centres. The children's ward disappeared. The whole second floor surgery ward disappeared. It became a multi-million-dollar office space. CEOs were being rewarded for cost-cutting with bonuses and career advances. Big cuts, yet we were a thriving tourist town and our population was increasing, not decreasing. Our needs were increasing, not diminishing. As an aged person, let me tell you what it's like travelling long distances to a city hub. My husband had 9 weeks radiotherapy at Orange. He suffered horrible side effects, including loss of bladder and bowel continence. While driving him home on discharge, we had a flat tyre. My husband got out to help me, but his bowel gave out. There we were, 2 old people on the side of the road, one undressed trying to clean up, and the other one trying to help him and fix a flat tyre. My spare was too damaged to use, so we had to sit there for another hour and a half waiting for a tow truck to take us into Wellington. Travelling hundreds of miles.
Take your time.
Travelling hundreds of miles when you're sick or in pain is not a day trip in a flash modern car. When you're very sick, it's traumatic. My husband temporarily lost his sight last year from a stroke. We were sent to Dubbo for an MRI. I drove him. We waited in ED all afternoon to discover Dubbo Hospital didn't have an MRI. It has now. The doctor admitted him, and lovely doctor admitted him, and said in the morning she would discharge him and send him to Orange, which is about 2.5 hours away. There was no patient transport available. Thank you. So I drove him. We sat in Orange ED for hours, and they did the MRI and discovered he had had a stroke, but he had to go back to Dubbo Hospital because they said he was Dubbo's patient and Orange didn't have a bed for him. So I drove him back to Dubbo. Again, in Dubbo, we sat in ED again for hours before he was admitted. I did complain about this, but in a lot of spin, the officials denied that it happened and said he was monitored at all times. Well, there was no one in the car but me monitoring my husband. I understand the need to centralise some expensive, highly specialised equipment, but travelling hundreds of miles for basic medical treatment that 20 years ago could be done in the local general hospitals is not logical. Health executives, and I know this because of my journalism, are rewarded more for saving money than providing genuine health progress. And they are spending millions on spin doctors to facilitate it and protect it. Health money should be spent on more doctors and nurses who are just struggling so much, and we have some wonderful people and we should protect them and we should support them. Health executives, I feel, are turning us into country peasants with third world health offerings. I could tell you a lot more, but stop there.
Thank you so much for that, and thank you all for coming today. We're now going to move to questions. So we're going to keep the same format of about 7 minutes each, and we'll start with the Honourable Walt Secord.
Thank you, Mrs. Is it Simmons? Simmons.
Mm.
I apologise because I do recognise your name now, because years ago I think I encountered you when I was a media director to Premier Bob Carr. You were at the Mudgee Guardian?
Yes, I was at the Mudgee
Yes,
Guardian.
I think I encountered you.
I retired 12 years ago.
Yep, so I would have encountered you. So what services are available? Is it Mudgee District Hospital?
Mudgee had its old hospital crashed down, demolished.
Yep.
And after putting that multi-million-dollar fantastic offices on the second floor and communications, etc. So that was all taken away and a new hospital built. And it's, on the surface, a lovely modern building, but everyone's still sent to Dubbo. If it's too complicated, I mean, I've been in there with heart problems many, many times, and they've taken wonderful care of me, but my husband has been shipped out for many times. Even in the building itself, there's just so many, it was just slapped up. And I just feel that the health department is spending money on all these wonderful buildings and demolishing all our old hospitals and building these wonderful new buildings, and the money's going there instead of going to the patients and the doctors and nurses. Doctors and nurses can work in an old building far better than a new building that's empty.
Now, do you know what services are available at Mudgee Hospital?
We've got an emergency department.
Mm-hmm.
We have doctors most of the time. I understand sometimes we have to resort to the television thing. Mm-hmm. We've got nurses. I think we've got a maternity ward. I don't think we have a children's ward. I think they all get shipped out if it's not minor. I'm not sure what else, because frankly for the last 6 years I've been looking after my husband full time, and my hands have been, and my mind has been there. And that's why I can tell you firsthand, watching what happens and watching people work so hard. And in my own family, I've got a doctor, a nurse and a radiographer. I know how hard they all work and how frustrated and tired they get sometimes.
Thank you. Mrs. Richard, so your relationship or your submission relates to Kula MPS, is that correct?
Yes, and the provision of GP services.
Can you speak closer to the microphone? Thank you.
at the provision of GP services.
So what is your feeling how do you feel? Do you personally go to Kula MPS or do you go somewhere else?
Fortunately, I haven't had serious problems lately. I did have a heart checkup and I went to a specialist at Dubbo before Christmas. But this year, since we've not had a GP and now we have one who has limitations, I still haven't needed his services.
Now, Mrs. Simmons, what would you like to see happen at your local hospital?
At our local hospital and hospitals across country areas, I would like to see basic general hospital that can do basic things with a doctor at least on duty, well, depending on the population, more than one doctor, but people on duty who are not harassed so much by overwork that they can cope with what's happening. I know it's very hard to put expensive, you've got to have your hubs for more serious things. Yeah. Money for patient transport and sort of thinking about the realities of people travelling hundreds of miles when they're in pain or they're sick or whatever. For children, I fancy living in a town that doesn't have a children's section in their hospital. I'm glad my children are grown up.
Mrs. Staggs, what would you like to see to happen at your local hospital? And your local hospital is Gilgandra.
It's a multi-purpose service.
MPS,
and
sorry.
actually, when it was a hospital, it was a jolly sight better, like everybody else is saying to you. And I have to agree with so many of the comments about the fact that it seems like it is the people above, the nurse managers and the general managers, who are making the decisions without any community input at all. That is my big concern. My concern with my friend in there, as I've pointed out, was over the Christmas period, they told the community nurses that they had to take 2 to 3 weeks holiday. There was no choice about it. You've got to take it. The fact that they wanted to stagger it and always have a community nurse person on hand was no consideration taken to that. They just have to take your holidays and that's it. Now, we're at the junction of 3 highways. There's often accidents. So we're emergency, we are critical care, and we're also palliative care in the hospital. There'll be 2 people rostered on there. I found that because there was everybody away, my daughter-in-law, incidentally, is one of the community nurses, and the local physiotherapist said to me, when on earth is she coming back? And I said, well, she's on holidays. They've been told they've got to take their holidays. Now, they were being run off their feet, the physiotherapy, all the allied health people, because at that stage all the GPs have a holiday too. And
so who was at the hospital?
Yeah, well, that's about it, isn't it?
No, I'm asking you the question.
Well, I can tell you there's 2 people, and I would go early in the morning to see my friend who was terminally ill, and the hospital doors would be locked because with 2 nurses there, they had for their security, you mentioned about a drug person, this sort of thing happens. They've got to have the front door locked because there's nobody on reception. So how do you care for all those sections of the multi-purpose? It's certainly multi-purpose these days. It's not a hospital. It's just trying to look after. And so you've got these girls who are trying to do their best to look after the patients that they've got there, but they've also got to be safe that they're not going to be attacked inside.
So 2 nurses responsible for how many patients?
Yeah, I can't answer that. I'm not on the staff, but I don't really know. There's there's emergency, there's the critical care patients, the chronically ill people, which is my friend that was in there, who had experiences that I can relate to in that she had to have radiotherapy at Orange Hospital. They couldn't accommodate her in there, so they put her at Marlong, and she had cancer of the spine. She was transported in many cases, sitting up in this patient transport, and she said it just hurts so much getting to have her radiotherapy, to go back from Orange Base to Marlong. who were nice enough to take her in. And of course, one of the nurses was so good, she used to come and visit my friend in Orange because she was from a small community who realised that she had no other family down there, nobody of support, but she was just a number at Orange Base Hospital. And the best care she honestly got was in Gilgandra with the people that knew her and knew her state of affairs. And keep this in mind for the government, we need that community input because we know what's going on. When it's a decision made in Macquarie Street or wherever it's made about what the budget can be, you get two people who are overworked, probably underpaid. Mostly they're not worried about their pay. They're worried about the care of their patients. And I have seen my daughter-in-law in tears, worried about what was going on because she's bright enough to realise that, well, somebody had a perforated valve and she couldn't talk to any doctor to do anything to back her up. Now, they're the realities that, unfortunately, giving money to people who are further up the food chain, get bigger salaries in more probably wonderful conditions, but they are not seeing what's happening to the patients, to the staff, to the communities. My heart goes out to all the people that have spoken in small communities.
Thank you.
Because Dubbo is not an answer for us only.
Thank you. I'm just going to move on to Ms Fairman.
Thank you.
Thank you. I just wanted to, I might turn to the submission that this committee has received by the government in terms of how it says it's working for regional communities. And the government submission says that multi-purpose services is actually a response to what they see as challenges of rural and regional healthcare. And they say that this is an adoption of contemporary models of care. The submission says that multi-purpose services increase access to local healthcare services that provide sustainable health services in small rural communities to meet the needs of local communities. Is that happening? Is that your experience with multi-purpose services, Mrs Simmons?
Well, 20 years ago, the government could do a lot better. Why can't they now?
So multi-purpose services 20 years ago, so is that what you mean?
No, not multi-purpose,
No,
the
yes.
old hospitals.
Yes.
20 years ago could actually provide immediate health service, basic health services for their communities. Now, that's not happening, especially for the multi-purpose units.
And that's because of, why is that? Is that because of cost cutting? Is that less
I believe
staff
so.
for the patient needs?
Lack of staff is cost cutting, isn't it?
Yes.
Because they will not pay staff and people don't want to come, A, because there's not enough pay, but B, I suppose they're missing out on their career advances, not being in a big public hospital where there's opportunity. If there was, as people have been saying, scholarships to pay for country doctors and nurses to be trained, but also on the need for advancement and being elite, if that country training was seen as a badge of honour because of the experience, the variety of experience country medical workers get, when there's advancements in career coming, I think that would help as well.
Can I also add to that? I'm only 3 years retired from the local high school, which is alongside the multipurpose centre, and I had the role of welfare person there, so I was constantly dealing with the hospital or the MPS about things. 20 years ago, yes, it was better in Gilgandra. We had doctors there with their wives and their children going to the school, and they had the sort of services that we're now missing out on. So the statement, okay, we are an ageing population, I realise that. We have a big need for palliative care, but we've got to get the people that are in the community, that they will come back to us. I belong to what we call the Country Education Foundation, and I promote people going. We've had several girls and boys from Gilgandra High School go and become doctors and go into allied health. Now, those people will come back to a country area We need the GP rural training system, but we need to encourage country people because they understand our community. The person in the city who's doing the figures doesn't understand the community.
So this government submission, I need to be quite quick, I think, because I probably only got one question left in terms of time, but the submission does say that this submission, this is the government, demonstrates significant progress in the delivery of healthcare in rural, regional and remote areas of New South Wales. Everything we have heard today and the previous 2 days seems to just be the exact opposite of that statement.
It's not progress.
So the change, the reform, if you like, from to these multi-purpose centres and removal of the district, the hospital boards, all of that we've heard, from your point of view, the three of you here today, has that been successful?
No, it's not working.
No, the local input, as the gentleman said from Warren, I think, that's what you need. You have to have that local input because they don't understand the fact that, you know, we can have those accidents happening, we can get those things happening, and we can have the local druggie appearing at the doorway too. So, yeah.
I'd like to say that it's a building, it's not a facility that caters for the community.
Yeah, thank you.
I've just got one question before we'll move on to government questions to wrap up the session. Mrs. Richard, you mentioned in your submission about a really good standard of care of the nurses and other staff going above and beyond.
Yes.
Are you concerned that they will get to a point of burnout because they're having to go above and beyond over and over and over again and doing extra shifts? So, you know, we heard a lot of evidence today.
Yes, certainly that is what is happening. We've lost some wonderful, highly trained nurses because their lives fall apart outside the hospital because of the hours and the strains and the stresses.
Yeah. Thank you. Thank you. I'll go to the government.
Thank you, Chair. And once again, and I've said to all the witnesses today, thank you very much for coming in today. I think it's been really important and valuable to get your insights. I guess talking about the multi-purpose centres, as we've been doing for much of the day today, I know there's been a lot of, criticism of those, but throughout this inquiry, we've heard some good stories as well. Do you have any, positive stories? I guess what I'm worried about is that there are advantages to the model, and there are some good stories that come out of it. Same like telehealth. I mean, there's a lot of good stories from telehealth around things like the tele-stroke service, where they're able to provide stroke services using a specialist stroke doctor who can actually give real-time information, and it's saved a lot of people in rural and regional communities. So I'm really cautious about demonising MPSs and about demonising telehealth. Do you have some of those good stories, perhaps, and do you think you might be able to share them with us?
I've got one. Yeah. Now, with my patient, my friend, she was so ill she did not want to come to the oncologist in Dubbo. It was so uncomfortable for her. Yep. So we did an AVL and she wanted me to speak to the oncologist. Yep. And it worked really well because basically all she wanted, she didn't want chemo, she didn't want radiotherapy, she wanted pain relief.
Yep.
Now, that was a really good solution for both him as the oncologist and my friend, because she, by that stage, was not feeling well enough to do it, but she wanted me to sit and talk to him about it. Yep. Now, that was an advantage, but that's right at the very end of a person's life.
Yep.
And there are advantages. The point about the fact that you've got the palliative care, you've got the aged care, you've got the critical stuff in together in some ways, but you've got to have the staff. Yeah. It's no good having the bestest building in the world if you've got nobody there to work for. So, sorry.
And you're right. What we need to do is we need to, I guess, bring the community along with us and engage with them around these issues. But it's really important that you actually shared that story with us because, you know, again,
You want something positive, I understand. You won't sleep tonight.
No, it's not just that. I just think it's really important that we hear the good with the bad, because I think there's issues around the community having trust in this as well, and you know, we need the community to trust in our staff, in our services as well, and it's not every story is a bad one. So you know, I thank you for that, Ms. Simmons. I just wanted to talk to you about your experiences and
Can I just add to you one about the telehealth thing? My husband's stroke doctor has spoken to him numerous times on the telephone with pictures and things.
Yep.
It works. That's good. It's follow-up and it works, and he directs our doctor to get various tests done, and then he has those test results in front of him, and then he can talk to Peter about those, and that works. That's another good story about those. But your best good stories are in the doctors and nurses who are trying to do all this work.
Yeah, and that's, I think the other thing is that I want to make sure that our staff know that they're supported as well, and I just fear that sometimes if we keep focusing on the negatives in these aspects,
I agree.
It's demoralising for the staff, and the staff are doing such an amazing job on the
They
ground,
are.
and we really need to support them.
Yep.
So I think that's really important.
My husband and I have had incredible kindness and expertise and help, and it's been, you know, it's been wonderful. But we have eyes to see what's happening as well.
No, and it's those experiences that are really important.
Wes, let's agree that patients, doctors, and nurses are being let down by the government.
No, please, please don't.
We've had a very civilised day, Mr. Secord.
Yeah, please do not do that, Walt. I mean, that's just not appropriate. The last question I wanted to ask Ms. Simmons was around, you know, your experience, I guess, being transported, you know, with the transport and stuff, and I guess you providing that transport.
I'm 74 and I'm driving him around.
I'm 74.
Yeah, I am.
How do you think that provision might have been done better? Like, how would you have, what could we have done, do you think, to have made that a better situation for you and your husband?
Well, I'm not quite sure. Perhaps patient transport. He was in and all the men that were receiving that treatment over there, beautiful place to receive the treatment, but we were there for 9 weeks, and he's not the only one. Probably more help personally with personal transport, etc. If Peter hadn't have had me, if he'd have been by himself, well, I don't know how he would have coped. It is a problem going long distances. Another time going down to Westmead, I was in hospital and Peter waited, 70-plus-year-old man, really ill himself, sat in the waiting room all day waiting for me to have my operation, and I didn't go for some reason in till the evening. Then I had complications with anaesthetic. And it was after 11 o'clock when they let my husband out the doors. No taxis there, no one offered him any help, in a strange place. He had to walk about a mile to where we were staying, and some young fellows come up behind him, and he heard them coming up behind him. He immediately rang our daughter and turned around to face them on the phone, and he heard as they walked past one of them say to the other, "I told you should have moved quicker." What could have happened? You know, I don't know the answer. There's a lot of smarter people than me who could think this through. I don't know what the answer is.
But I guess it's that tyranny of distance that we all, I guess, face living out here, and you know, your insights into it, you know, this is something we can, try and help you with and try and address, not only for you but for other people. So thank you very much again for coming and sharing that with us. I think we're out of time.
You're done?
Are we, Chair?
Yes, you are, yes.
Thank you again.
Thank you. And I thank you all for attending today and providing evidence. Thank you for coming and speaking with us. We truly appreciate it. That actually concludes our hearing for today, and the broadcast will now cease.